avoid overheating the patient's internal organs. This is just a schematic of the HeartMate 2 LVAD. This is a continuous flow support system with mechanical bearings with the pump located subdiaphragmatic. So as you can see, the pump is subdiaphragmatic. Then peristernally, you can see the outflow graft, which is then attached to the ascending aorta. The biggest concerns with the HeartMate 2, i.e. the need to develop the HeartMate 3, was pump thrombosis, stroke, and GI bleeding, as well as hemolysis. The hardware LVAD is also a mechanical pump. However, it is smaller and lighter. And this pump location is now intrapericardial versus subdiaphragmatic with the HeartMate 2. Still has the right peristernal outflow graft, which is then anastomosed to the ascending aorta. The HeartMate 3, which was approved as of October of 2018, has a pulsatile pump without mechanical bearings, utilizing a fully magnetically levitated flow. This has resulted in less pump thrombosis, significant reduction in strokes, and a longevity of the device. Almost all of the information that I will be presenting today is from the 2015 ASC guidelines, Echocardiography in the Management of Patients with Left Ventricular Assist Devices, recommendations from the American Society of Echo. I urge you to read these guidelines, and in fact, in preparation for boards, I would tell you that all of the guidelines are excellent reads. And if there was a choice of where answers to questions would be coming from, I would tell you the guidelines are the source. So this is just a list of the pre-implantation TTE and TEE findings that would be considered red flags. And I'll be going over these in more detail. But there are situations within the left ventricle and the interventricular septum, the right ventricle, and you will see within this lecture that there are going to be repetitive concerns and repetitive things that I will want you to focus on. The right ventricle is key. The size of the right ventricle and what is the function of the right ventricle pre, during, and post LVAD implantation. Looking at the atria, the intraatrial septum, and the IVC, valvular abnormalities are very important, both native valvular abnormalities and prosthetic valvular, not only abnormalities, but some of these prosthetic valves need to be addressed even when they're normally functioning. And then other issues include congenital heart disease, the pathology or lack thereof of the aorta, if there are any mobile masses, endocarditis, and shunts. So the left ventricle, obviously that's the ventricle that we're mostly keen on talking about today. And the qualifying diagnosis from CMS is that the LVEF has to be less than 25%. However, a severely decreased LVEF is by no means the only clinical parameter used for determining whether or not a patient is referred for an LVAD. Heart failure specialists must estimate a patient's survival and the suitability for an LVAD. I also want to urge, and because I do think this is underrepresented in the guidelines, the liberal use of IV contrast to enhance the LV cavity and the endocardial borders. To estimate the LVF, the Simpson's biplane method of discs is the optimal. The left ventricular internal diameter, diastolic diameter pre and post LVAD is a primary clinical measure of the degree of LVAD mediated LV unloading. A comparison of pre and post LV end diastolic volumes would be better to quantify the LV unloading. These measurements, though, can be very challenging to obtain secondary to patient positioning, mechanical ventilation, sternotomy, and bandages. So this is just a example of a 4-chamber and 2-chamber using the Simpson's biplane method of discs, which is the preferred method for the LV size. This is preferred due to the fact that if we all recall that in the parasternal long axis view, when we're getting linear measurements, those linear measurements do not include if there's any aneurysmal remodeling of the LV apex. So they don't take into consideration the relative contribution to the function of the base or mid segments of the LV relative to the apex. And this could cause underestimation of the LV size and also overestimate the LVEF. Limited data suggests that an LV internal diameter at the end of diastole less than 63 millimeters is associated with a higher 30-day morbidity and mortality. These smaller ventricles tend to be in elderly women, patients with smaller body habitus, and those who have infiltrative disease. And regardless of the infiltrative disease, again, and as I said, you'll hear me reiterate over and over again, some common themes is RV function. So RV dysfunction associated with infiltrative disease demonstrates a high risk and is not an absolute contraindication to LVAD implementation, but this must be communicated amongst your heart failure team and surgeons. The concern for intracardiac thrombi are that it's not necessarily absolute contraindications, but they do portend increased risk. They may increase the risk of stroke. And again, in patients who have a history of atrial fibrillation, I would strongly urge the use of IV contrast enhancing agent, especially during your TEE, to look at the left atrium and the left atrial appendage. Removal of any intracardiac thrombi may be required prior to the LVAD implementation, but communication again to the surgeon is imperative. RV function, RV sized should not be assessed in isolation. And the reason why I say this is that the RV can also be very difficult to see in these patients who have very large LVs. So all of the parameters to obtain RV function and size may be limited, but try to get as many of the parameters as possible. Fractional area change, TAPSE, RV free wall strain, as well as 3D assessment. If these parameters are difficult to obtain, quantitative assessment is obviously recommended for the RV, but at minimum, a qualitative assessment of the RV size and function and the degree of tricuspid valve regurgitation should be performed. With RV dysfunction, this does portend a worse outcome. It has been found that RV strain less than 9.6% and a ratio of the RV to LV end diastolic diameters greater than 0.75 are independent predictors of poor outcomes. And again, aggregate assessment of the multiple echo parameters is recommended. Indexed left atrial volume, indexed LV size, LV parameters, severity of the TR, RA pressures, and IVC size, and if possible, respirophasic responses. Valvular stenosis relative to the mitral valve must be corrected prior to LVAD implantation. This is because there's a reduction to LV preload, preventing adequate LV left ventricular assist device inflow. Interestingly, though, aortic stenosis of any severity can be present without affecting the LVAD function. The LVAD function cycles completely bypass the native LVOT. However, it must be remembered that with severe aortic stenosis or surgical complete surgical complete AV closure, the patient will have no escape route through the native LVOT in case of obstructive LVAD failure. And this is very important to remember. So if your patient goes into an LVAD and has known severe AS, but there's then an obstruction to flow of the LVAD, this could be devastating for the patient's hemodynamics. Again, you'll see here's some common themes: aortic insufficiency. Exclusion of significant AI is critical before LVAD implantation. The reason why is that significant AI will create something called a blind loop. The flow will go from the LV to the LVAD to the ascending aorta and then back to the LV, and obviously not help the patient's hemodynamics. There must be a high level of suspicion for AI. The AI may be difficult to assess by color. This may be due to the fact that the unimpressive color flow Doppler images and low AI velocities due to a low systemic pressure, yet high LV and diastolic pressures. Additionally, the regurgitant fractions of the AI may be relatively low despite a high regurgitant fraction. Doppler-derived LVOT stroke volumes and fractional regurgitation of your AI should be calculated routinely. And T is highly recommended in order to better assess your valvular regurgitation of your aortic insufficiency. Surgical correction of the AI before LVAD implementation can be done with an aortic valve replacement, completely oversewing of the aortic valve cusps, or a central coaptation stitch called a PARC stitch, which can treat central AI and allow for LVOT outflow. This is a TTE color Doppler showing moderate aortic insufficiency before LVAD implantation. Intraoperative assessment revealed that there was subtle cusp prolapse with good tissue integrity, and thus a PARC stitch. You can see the arrow in the image B indicating the PARC stitch of the parasternal long axis, as well as in the parasternal short axis of the aortic valve. And then the M mode image shows residual cusp separation near the cusp commissures during reduced LVAD pump speed. So again, this is important to note that with the PARC stitch, you do still have availability of some LVOT outflow. MR, on the other hand, tends to improve post-LVAD support. This is due to reduced LV size, reduced filling pressures, improved mitral valve coaptation, and really any degree of MR is acceptable. However, MR that develops post-LVAD, which we will talk about later, is important to note. Moderate or worse TR is an ominous sign, and consideration of tricuspid valve repair prior to the LVAD should be discussed. Pulmonary insufficiency may actually be well tolerated pre and post LVAD with adequate RV function and LV unloading. Significant PR, though, could potentially contribute to RV dysfunction if the pulmonary vascular resistance increases post LVAD or there's an inability to adequately unload the LV. So again, aortic stenosis, mitral valve regurgitation, mild TR, and pulmonary insufficiency may be well tolerated during and after an LVAD, but still must be regularly monitored. Prosthetic valves pre-LVAD implantation require an INR if they are mechanical valves. Interestingly, though, the LVAD support will reduce the flow through a mechanical aortic valve, which increases the risk of valvular or aortic root thrombus and obviously embolic events. So replacement of a normally functioning mechanical AVR may actually need to be considered. Bioprosthetic AVRs may be well tolerated. Typically, normally functioning mechanical valves are not needed to be replaced, even with significant mitral valve regurgitation, as obligatory forward transmitral flow will occur during an LVAD support. An important exception, though, is prosthetic mitral valve stenosis. In these cases, consideration should be given for a mitral valve replacement with a bioprosthetic prior to LVAD implantation. And this is not dissimilar from native mitral stenosis. Not frequently encountered, but tricuspid valve or pulmonic valve prosthetic dysfunction is an important finding, as it could adversely affect post-LVAD implantation RV function. So I hope you're hearing some common themes again to keep in mind, things that we have to follow pre, peri, and post-LVAD implantation. With amendable cardiac anatomy, even patients with complex congenital heart disease can have an LVAD for bridge to transplant or destination therapy. However, PFOs or other intracardiac communication should be closed at the time of LVAD implantation, as these increase the risk of hypoxia as well as paradoxical emboli. In most cases, a VSD, whether it is congenital or post-MI, is an absolute contraindication to LVAD implantation. IV agitated saline study with appropriate Valsalva maneuver must be conducted to exclude right to left communication prior to LVAD. This is a classic finding, a perioperative TE showing marked RA to LV shunting with an unmasked PFO, which became apparent immediately after the LVAD activation and resulted in significant hypoxemia. This unmasked PFO was noted when the Nyquist limit was lowered to show the flow. Other high-risk findings: acute endocarditis is an absolute contraindication for obvious reasons due to the risk of infection and of seeding the device. Aortic pathology is very important to understand and observe beforehand because of the graft needed to be anastomosed to the ascending aorta. So aortic aneurysms, aortic dissections. High peristernal views of the thoracic aorta are important. And if these views are limited by transthoracic or transesophageal, then CT or cardiac MRI is recommended. So the pre-implantation TEE, again, this may be the only source of imaging prior to an LVAD, especially in urgent or emergent cases. So the degree of AI must be appreciated. As I stated earlier, this may be underappreciated by color Doppler, especially in patients with general anesthesia because of low mean arterial pressure and or low SVR. As a result, the blood pressure may need to be augmented with vasopressor agents during the pre-implantation TE assessment. Again, with regard to the intracardiac shunts, especially PFOs and ASDs, lowering the Nyquist limit and an IV injection of agitated saline combined with ventilator Valsalva maneuver and then release is imperative. And even with this, PFOs, ASDs may be missed secondary to negative contrast by competitive IVC flow. Thus, injection of IV agitated saline via a femoral vein may be able to help with this. And again, shunting may be missed and unmasked post-LVAD because of the lowering of the LA pressure. Just a list of the TE findings that you want to make sure you note on your report. In addition, you also want to report the blood pressure and any other findings that you may find that were possibly not realized or unexpected before LVAD. The perioperative TE has many risks and many findings that you must keep an eye on. Your cardiologist that is assisting with this portion of the test must be ready when any of the indications possibly appear that could be red flags. One may be air entrapped in the LV. It's inevitable to have entrained air in the left side of the heart during the coring of the LV apex for the inflow cannula. Because of the ostium, the RCA, being situated anteriorly in the aortic root, it is a common destination for air injected from the LV. So if there's the acute finding of RV dysfunction or RV dilatation or increased severity of TR, these should all suggest the possibility of an air embolization to the right coronary. Watchful waiting. If that does not improve, then going back on bypass may be necessary, and there may be the need for repeat de-airing maneuvers. After LVAD implantation, you want to look at the implantation of your inflow cannula. This is a TEE, which reveals a typical unobstructed inflow cannula. And by use of X-plane, you can see it in an orthogonal view. And then in the image B is a beautiful 3D showing the normal appearance of the inflow cannula. What also should be noted is the relative normal size of the RV. This next view is an LVAD after implantation. The T shows the inflow cannula, and the inflow cannula on this one is somewhat directed towards the ventricular septum. This may be acceptable, but it may predispose to inflow cannula obstruction after sternal closure or later when the LV is reduced in size. However, as you can see in figure B, that the flows are normal. So in this case, in the image B, the pulse wave Doppler interrogation of the inflow cannula shows a typical continuous systolic dominated inflow with the nadir diastolic. So the dashed line is the systolic flow and the solid line is the nadir diastolic flow. In image C, you see the continuous wave Doppler interrogation of the inflow cannula. That's the arrow. And then you will see with the asterisk, the MR. And then you will see with the plus sign, that is showing a hybrid of the systolic and systolic mitral valve or diastolic mitral valve inflow and the diastolic LVAD flow. So on figure C, you see three different flows. You see the systolic flow of the inflow cannula. You see the diastolic flow of the inflow cannula, and this is obviously for a continuous LVAD support system. And then you can also see the mitral valve regurgitation. Again, perioperative TE is important because of the hallmark that occurs with hypoxia and the sudden onset of decreased arterial oxygen saturation with an unmasked PFO or ASD or VSD. And again, this is 30% of the population have PFOs. So this is something that must be diligently evaluated pre-LVAD and then again peri-LVAD. The aortic valve opening and the degree of AI, again, common theme here, is important. And a slow sweep speed of 25 millimeters per second may be needed in order to acquire enough cardiac cycles to determine if the aortic valve opens intermittently or minimally. And obviously this depends on the amount of LV support and thus decreases with more LV support, i.e. a higher pump speed. M mode of the aortic valve in long axis view is helpful. So when you're looking at the degree of aortic valve opening and degree of AI, you want to look at your parasternal views, your short axis views, your M mode views, and your M mode with color. So this is an assessment of aortic insufficiency. This is a TEE showing at least moderate, possibly severe AI, and it's actually continuous because this is during LVAD support. Using our typical parameters of the AI, it is clearly, the vena contracta is clearly greater than 3 millimeters. The jet width to LVOT width is clearly greater than 46%. In addition, you can see in the image A, entrainment of the AI as the flow goes out of the inflow cannula. And this can be seen in both image A as well as image B. During the LVAD support in image C, you can again see that the AI is at least moderate and is continuous. And in images D and E, interestingly, in this patient, despite going up on the LV support, and unloading of the LV, the AI actually worsened. And in this case, this was felt to be possibly due to an increase in systemic vascular resistance because of the AI, and thus increase in the systemic vascular resistance because of unloading of the LV and then resulting in more AI. So again, we can use many of our parameters for assessing AI as we would without an LVAD, and that would be a vena contracta width greater than 0.3 centimeters, a jet width to LVOT width greater than 46% when the Nyquist limit is appropriately set at 50 to 60 centimeters per second. Remember that with LVAD support, AI duration extends into the systolic ejection period. And this is very important to note. Pressure half time nor diastolic flow reversal are reliable post-LVAD implantation. And this is because these are both highly dependent on preload, afterload, and aortic pulse pressure, which are all going to be reduced post-LVAD. Poor RV performance is not uncommon to be seen due to the rapid normalization of the RV preload by the pump. So again, another common theme, you want to be making sure that you're looking at that RV pre-LVAD, but post-LVAD, don't become immediately alarmed if the RV performance does decline. This is exactly what I said. This can be normal and results because of the RV preload is increased. And this can occur with or without tricuspid valve regurgitation. RV dysfunction may be transient due to being on bypass or refractory due to underlying RV function, which may have been noted or missed. And the TR may be present despite optimal LVAD pump speed. So again, if the TR is present, but your RV function is stable, unchanged, or normal, this may not be an issue, but does need to be monitored post-LVAD. Excessive LVAD pump speed may precipitate acute RV dysfunction with acute severe TR. If the LVAD pump speed is set too high, the LV may be small and sucked down, resulting in a shift of the interventricular septum from right to left, which makes the LV small, but it distorts the RV shape, which also distorts the tricuspid valve annulus, worsening the TR and worsening or resulting in resulting in RV dysfunction. This cascade is called a suction event. And again, it's due to a segment of the LV partially occluding the inflow cannula and reducing pump function. And this is a nice image of what that exactly happens. This was suspected after the HVAD was activated. So initially, everything was fine, the hemodynamics were fine, and then suddenly there was a development of hypotension and LVAD flow cessation. A relook in the mid-esophageal two-chamber view showed that there was LV cavity obliteration, and the inflow canalization was obstructed by the anterior LV endocardium. There was restoration acutely of the LV size and normalized LV function with reduction of the LVAD speed. So you can see at the LVAD speed of 2,400 RPMs, and then at the LVAD speed of 2,200 RPMs, restoration of the LV size and release of that suction event. However, it's very important to look for other causes that could have resulted in hypotension. The aortic valve opening, the relative LV and RV sizes, the degree of TR, the positioning of the ventricular septum, position of the inflow cannula, which may result in significant MR if it is interfering with the subvalvular apparatus of the mitral valve, flow velocities, hypovolemia, or sepsis. When a sudden event occurs at low pump speeds or RV dysfunction persists, then there may be a need to go back on bypass and may need the addition of biventricular support. The inflow cannula lies near or within the LV apex with the tip directed towards the mitral valve with just some slight angulation towards the septum. Direct contact of the inflow cannula with the septum can result in ventricular arrhythmias or inflow obstruction. And there must be avoidance of the interference of the inflow cannula with the mitral valve apparatus. As I stated, this could result in mitral valve regurgitation. Typically, the HeartMate 2 flows are typically less than 1.5 meters per second. They are laminar and unidirectional with uniform systolic augmentation and no regurgitation. So this is just a nice depiction of a normal HeartMate 2 inflow cannula. This required the use of a modified peristernal long axis view for coaxial alignment for the pulse wave sample volume. The color flow Doppler with the pulse wave sample volume of the inflow cannula can be seen. And in images B and C, we see normal flow. It's laminar, and the peak systolic flow is approximately 1 meter per second, and a nadir diastolic flow of approximately 0.3 meters per second. This is an example of a normal LV apical inflow cannula and flows. On the other hand, this is a side-by-side comparison of an LV in the peristernal long axis, A showing normal LVAD function with an end diastolic diameter of 5.3 centimeters and an aortic valve opening of 107 milliseconds, that's in image C. With LVAD thrombosis, you can see that the LV end diastolic diameter actually dilates from 5.3 to 7, and the aortic valve opening increases from 107 to 230 milliseconds. The outflow graft, the proximal graft, is not typically well visualized. The mid portion of the graft can be seen lying adjacent to the right heart. The distal outflow graft to aorta anastomosis can be seen in most patients. The spectral Doppler interrogation should be done coaxially with the direction of flow. This flow is also typically low velocity, laminar, and unidirectional with some variable degree of systolic augmentation. However, it should be noted that outflow peak systolic velocities greater than 2 meters per second at any level is considered abnormal and should be investigated. Sternoclosure can change the orientation of the inflow cannula or the outflow graft relative to the chest, open chest positions. Thus, it is critical to reevaluate the orientation and flow characteristics immediately after sternal closure. This is just a image showing the LVAD outflow graft as assessed by TE. In the images A and B, these are modified mid-esophageal four-chamber views. And you can see the outflow graft, which is frequently seen in the near short axis orientation. And then you can do, of your B image, you can do an X-plane so that you can nicely see more of the outflow graft riding along the right parasternal image view of the heart. And then C is showing successful post-Doppler interrogation of the outflow graft. This is a T of the outflow graft to ascending aorta anastomosis, showing both, 90-degree axis so that you can see the flow in two different views. B is a post-Doppler profile, and C is a continuous wave Doppler with this peak systolic velocity that is expected. It's somewhat higher than 100 centimeters per second, and the solid line indicates the nadir diastolic flow. And in the image D, I want you to take a good look at that because that's showing a normal outflow graft 3D image, and I will show an abnormal outflow graft 3D image later. So what pump speeds do we use? For different centers, there are different philosophies. The intraoperative pump speeds that are felt to be optimal may not be appropriate later though. So the optimal speed may be minimizing the left ventricular end diastolic volume in systole, or the optimal speed may be minimizing the left internal diameter during diastole with intermittent aortic valve opening. And some centers, though, consider optimal speed when there's maximal LV unloading with the aortic valve completely closed. And this is just a nice depiction showing the aortic valve opening with different LVAD speeds and showing how easily this can be measured with M mode. With image A showing that the aortic valve barely opens intermittently, and this may be normal or may be associated with arrhythmias. B is near normal aortic valve opening with durations greater than 200 milliseconds. And C and D are showing different variations of the aortic valve opening at different LVAD unloading, with D showing that the aortic valve opens intermittently, and in E, the aortic valve remains closed. And these are all three in the same patient, but showing how the aortic valve opening can be depicted and measured with M mode. Here's a T showing the characteristic severe AI that may be due to cusp fusion. And this occurred in a patient after long-standing LVAD support. You can see that there's thrombosis on the aortic valve. And in B, the significant aortic insufficiency, which developed after long-standing LVAD support. C, D, and E are using the right pulmonary artery as a focus and looking in the upper esophageal long axis views to show the LVAD outflow graft. So the typical LVAD surveillance is at 2 weeks or prior to discharge, 1 month, 3 months, 6 months, 12 months, and then every 6 to 12 months thereafter. So long as there is absence of heart failure symptoms, successful weaning of inotropes, absence of LVAD alarms, and lack of evidence of hemolysis or infection. It is really important to note the blood pressure during all of the post-LVAD echoes. The blood pressure reflects the peripheral vascular resistance and affects the LV unloading. Blood pressure with LVAD support is possibly very difficult and reduced with a narrow pulse pressure. A palpable pulse may be or may not be present. Thus, a Doppler evaluation may be necessary. If there is a pulse, then the Doppler-derived blood pressure equals the systolic blood pressure. If there's no pulse, then the Doppler-derived blood pressure equals the mean arterial pressure. And we want the mean arterial pressure to be less than 85 millimeters of mercury. And if a patient's mean arterial pressure is less than 60, then the patient can have signs and symptoms which are traditional for hypoperfusion. The peristernal long axis view is the most reproducible to obtain the LV dimensions. You may need to use the EKG to determine diastole and systole. It is expected that there should be a 15% reduction in the LV end diastolic size after 3 months of LVAD support. The LV end diastolic diameter may be paradoxically smaller than the systolic dimensions if there is excessive LV unloading and or if there's severe RV dysfunction. As I stated before, volumes after implantation is more difficult, more reliable, but more difficult due to apical shadowing or dropout associated with the inflow cannula. Preferred method for calculating the LVF is the biplane method of discs. Liberal use of IV contrast enhancing agent should be given. Methods of estimating the LVF based on LV stroke volume are not recommended due to beat variability. And it should be noted that with LVADs, it is not vastly unusual to see that patients' LVF stays moderate to severely reduced. Relative to diastolic dysfunction, patients who are receiving an LVAD typically all have markedly abnormal diastolic function, and there's a paucity of data validating any of the standard diastolic parameters in patients with LVADs. And thus, putting into your report interpretation of the degree of LV diastolic dysfunction presumed abnormal is not provided because of continuous flow LVAD support. RV size, again, must be evaluated. This is very important, looking at the linear dimensions, the fractional area change, and right-sided cardiac output. And recent data suggests that TAPC should not be relied on because this may be a weaker parameter after cardiothoracic surgery. So when we're looking at the LVAD, aortic valve opening may not occur at any LVAD speed. Opening, you should note if it's opening with each cardiac cycle, intermittently, or remaining closed. There is something really important to note called pseudo-aortic valve opening, which I'll go over in greater detail in the next slide. And this is the false appearance of aortic cusp separation. There needs to be an evaluation of the aortic root for all patients, regardless if they have native aortic stenosis or a mechanical or bioprosthetic valve. And de novo AI does occur in 25 to 33% of patients. So this is a depiction of the pseudo aortic valve opening as assessed by M mode. And this should be suspected when the aortic cusp opening has a fusiform shape. Although the apparent M mode shows that the aortic valve duration, in this case, they thought it was opening at greater than 200 meters a second, that there was in fact very little or no opening. The factors that are contributing to this are the semilunar shape of the aortic valve cusps, the placement of the interrogating cursor to the left of the closure, and translational motion of the aorta. And noting the proper timing of the aortic valve opening is really important because had the LVAD pump speeds been adjusted for the pseudo-AS, this could have significantly affected the LV unloading of the LVAD and the patient's hemodynamics. MR tends to reduce due to LV unloading and improve leaflet coaptation. Persistent MR after the LVAD may indicate inadequate LV unloading or interference of the mitral valve subvalvular apparatus. And persistent or worsening of TR is important. Both functional secondary TR due to LV unloading, excessive LV unloading with suction event, elevated pulmonary artery pressures, or intrinsic RV dysfunction. It is important to look at the interventricular septum and note, is it neutral? Is there a leftward shift due to elevated RV end diastolic pressures, reduced LV preload, or excessive LVAD speed with suction event? Or is there a rightward shift with elevated end diastolic pressures from inadequate LVAD unloading, pump dysfunction, severe AI, or increased LV afterload? It's important to look at your standard and off-axis and atypical windows for looking at your inflow cannula and your outflow graph. Again, typically the inflow cannula will have a velocity of less than 1.5 meters per second, is laminar and unidirectional with uniform systolic augmentation and no regurgitation. Your outflow graph should also be low velocity of less than 2 meters per second, laminar, unidirectional with variable degrees of systolic augmentation. And it can be very difficult due to Doppler artifacts to evaluate your LVAD. And this is an example of a heartware where if you have the heartware cannula in the image, you get this very typical characteristic color artifact. Once you get the heartware cannula out of the image, as you can see in C, you can now interrogate your mitral valve. And here's another example of a heartware and the typical cannula artifact. The 2D peristernal long axis view as evaluated with the T. Typically, this color flow artifact is associated with the heartware. And due to this, the inflow cannula flow with a heartware must be surmised by other means, by the flow of the graft, the RVOT flow, aortic valve opening, and LV size changes. There are obviously multiple complications that must be evaluated with the LVADs. De novo AI, as we discussed before. Here's views of the AI. There was no AI at baseline. And over time, as you can see at 1 month, there became the development of trivial AI. And at 14 months, there became moderate to severe AI. And again, we can use some of our traditional AI assessments with the vena contracta. Aortic root thrombus is important relative because of the lack of aortic valve opening of native aortic valves, or in patients who have aortic stenosis or mechanical or prosthetic valves. And this is just a 2D image that I borrowed from the Mayo slides, looking at the stagnant flow in the aortic root, and then in the short axis showing the thrombus and stagnation. Inflow cannula thrombus, I showed us this slide earlier, and that can be noted with the fact that the LV starts to dilate, and the aortic valve opening starts to increase because the inflow cannula is obstructed. So the flow now starts going out the native LVOT. Outflow graft stenosis, and this occurs typically due to intimal hyperplasia. Here's progressive outflow graft anastomotic obstruction, identified more than 1 year after LVAD support. You can see the turbulent flow of the graft in B. In A, you can see that there appears to be a kink or some obstruction anatomically. C, what I wanted you to note with C is a beautiful 3D of the outflow graft showing just a buttonhole of opening, and this was secondary to hyperplasia of the graft opening. And then you can see typically the systolic flow, which is quite high at 3 meters per second. And this is just another depiction of an outflow graph, turbulent flow, and then the speeds in B and C definitely higher than 2 meters per second. And then I'd like to just show an image of a pericardial effusion. This is a patient who developed tamponade after LVAD implantation, which was suspected because of low LVAD flow responsiveness. You can see a large loculated pericardial effusion along the posterior lateral and lateral walls. And interestingly, you can see here that there is some respirophasic changes, which we don't typically see and we don't typically measure as we do in a patient who does not have an LVAD. But this was pretty impressive with the respirophasic changes, which are also associated with this significant pericardial effusion. Definitely, we want to know what the LVAD output is. And because of continuous flow, as you'll see in image B, the LVAD VTI includes the area under the curve for both the systolic and diastolic parameters. And you get the outflow graph diameter divided by 2 squared times pi times the outflow graph VTI times the heart rate will give you the LVAD output. And I think this is a very reasonable question to have on board. So I would note this equation. If though you want to know the total cardiac output, that would be combined LVAD flow and native LVOT flow output, if any. The RVOT cardiac output is measured by using the standard imaging techniques, measurement of the RVOT annulus, and the color flow and spectrodoppler. And so you can see here the RVOT diameter. We try to line up our Doppler coaxially with the flow, and we get our RVOT VTI. So our RVOT diameter divided by 2 squared times pi times RVOT VTI times heart rate. An interesting case of ours at Rush, this was a 61-year-old patient who had ischemic, a dilated cardiomyopathy, had a HeartMate 3 implanted on April 2nd. This patient had a history of cardiogenic shock requiring inotropes, had the HeartMate 3 implanted. I'll just show you this view. This is pre-HeartMate 2 implantation. You can see the LV is dilated with severe LV dysfunction, and the RV is small with good function. Here's the patient 1 day after the LVAD was placed. I brought in just the RV function because putting both the RV and the LV in the same view is quite difficult when you have both chambers dilated and dysfunctional. But you can see here, this patient developed RV dysfunction as well as a pericardial effusion. You can see the TR worsened. And here, after nice careful waiting, this patient did not require RVAD support. After careful waiting and patience, this patient, you can see 20 days after LVAD, the RV function is returning. The RV is smaller. And here's an image without IV contrast enhancing agent. Pericardial effusion is still present but stable, but the RV function has started to return. This is another interesting patient with an ischemic cardiomyopathy, got his device implanted on February 1st. I tried to grab the images that I could best depict the RV. You can see that the LV function is down, RV function is preserved. And here, shortly after the LVAD was placed, the RV dilated, there was RV dysfunction, and this patient did require an RVAD support. And here is his image after RVAD was removed. LVAD is still in place, but the RVAD was required for a few weeks, and this patient's RV function started to improve. This was an interesting case of a patient who had their LVAD placed, and we felt that the patient's LV function and need for LVAD was secondary to an ischemic cardiomyopathy. EF was 10 to 15%. He had his heart HVAD implanted December of 2019. And this is his pre-implantation LV. You can see that the LV is down. RA is pretty well preserved. Our RV is pretty well preserved. There's LA enlargement. RA looks normal size. Here's his strain. And we did look at the relative apical strain, which was not consistent with amyloid. However, after his punch biopsy came back from the core when his inflow cannula was placed, this patient actually did have amyloid. And the final case that I want to show is actually an ECMO case. This was an unfortunate 53-year-old gentleman who developed COVID and developed terrible hypoxia and hypercapnic respiratory failure. And we were asked to evaluate his transthoracic echo. And as you can see, the RA and RV are just filled with no understanding of, is this blood? This was not with contrast. This is a transthoracic apical 4-chamber view without contrast. So we were concerned if there was thrombus within the patient's RA and RV. We ended up giving the patient contrast, and we could see that the RV was huge, but the contrast was getting through readily to the LV. So we did not think this was thrombus. And what we found out is that when the patient went to the OR, he had breaks in the cannulas. And so that was all air within the system. And once his cannulas were replaced, unfortunately, this patient died, but the air was gone and the ECMO alarms no longer were ringing. So prior to placement of an LVAD, which of the cardiac anatomical structures findings need to be addressed or corrected prior, and why? And I can come back to the questions, but for the sake of time, I'm going to go to question 2. After placement of an LVAD, all of the following structural cardiac findings can get worse, except. And question 3, sudden onset of hypotension in a patient with an LVAD may be secondary to all of the following except. And I'd like to thank everybody for their time. I've included my email. So if anybody wants to email me at any time relative to echo boards, life, how to balance being a busy, non-invasive physician and the mom of 3, please don't hesitate to call me or email me. And these are my children, and this is a very old picture, but I wanted to honor my children for giving me their support. And that's my beautiful daughter, Bella, whose 18th birthday is today. So thank you, everybody. And I'm so sorry I went a little bit over.
Thank you very much, Melissa. That's an excellent summary, very detailed. And also, again, a very happy birthday to your daughter. We have 4 questions in the chat window. Maybe we can go over them quickly, you think?
Please.
Kofi?
Okay, sure. The first question was, do we have to close PFOs before LVAD placement?
Yes. If you know that a patient has a PFO before LVAD implantation, that PFO must be closed, because with unloading of the LV, the LA pressure will drop, and the LV unloading will then increase the preload to the RA and they will shunt. So those do have to be closed, and all means to evaluate for any intracardiac communication before LVAD implantation is imperative.
Okay, thank you. And then the next question is, can you show the LV output calculation again? And if you could go over it briefly.
Absolutely. Yeah, I do think this is the boards love to have equations or have you estimating flows. So I'll be happy to go back over that. And so long as they'll supply you on your boards with all the measurements, what they would like to do is give you information that you don't need, just to confuse you. So again, so I think this is the slide that they wanted me to be put back on. So this is the LVAD output. And so what you want to do is you want to get that view, probably a high parasternal view, so you can see that outflow graft be anastomosis, the anastomosis to the ascending aorta. You want to measure that, and then you want to get a coaxial flow so that you can get your VTI at the same point as you're measuring the diameter of your outflow graft. So that's not unlike anything else you would do. Like if you were going to do this out of your LVOT, you get your LVOT diameter and you want to get your pulse wave with your VTI. So you want to make sure that you can get the image A, and you want to make sure you can line up your Doppler signal coaxially. If you are have an irregular rhythm, which is very important, I did go over that, you do want to get at least 3 to 5 cardiac cycles. So if we go through the example, in this example, they got 2. So looking at A, they have the diameter of the outflow graft. In image B, they did 2 cardiac cycles, and for a continuous flow LVAD, you need to do the entire systolic and diastolic flow. So you would get your VTI, you would add those and divide it by 2. And that's where the equation comes in. So N is 2. The VTI of the first one is 21.2. The LVOT of the second one is 23.6. The heart rate was 82. The graft diameter was 1.3. You're going to get your average VTI by just adding those and dividing by 2, which will be 22.4. The LVAD stroke volume then is going to be your outflow graft diameter, 1.3, divided by 2 squared times pi times your averaged RVOT graft VTI. And then if you want to get your cardiac output, you're going to then multiply that times your heart rate.
Thank you. And then the last one, we have 5, but I'll email the last 2 since they will elicit a much longer response. The last one is, what about patients with CRTDs and ICDs? Are they candidates for LVADs as well?
Can you repeat that question? I'm so sorry.
Right, so patients with CRTD or ICDs candidates for LVAD?
Yes, as I didn't point out, but many of these patients have LVADs. So absolutely, because remember, the AICD is typically on the right side, or it can be within the coronary sinus. The inflow cannula is going into the apex. And then even if you have an RVAD, those are anastomosed distally. So a lot of these patients have AICDs, and the LVAD, they're still at risk for having arrhythmia. So patients still, yes, with LVADs or CRT can still get LVADs.
Thank you, Dr. Tracy. I appreciate your contribution to the ECHO series.
Thank you, everybody.
Thank you very much, Melissa. That was an awesome review. Thank you again.
I wish everybody very good luck and enjoy the rest of the conference.
Thank you. We want to introduce our next speaker, Dr. Purvi Parvani. Dr. Parvani is a cardiologist and assistant professor of medicine at Loma Linda University Health. She earned her medical degree from Gujarat University in India After receiving her residency training in internal medicine from University of Connecticut, cardiology training at University of Oklahoma, and advanced cardiac imaging training at University of California, San Francisco, she joined Loma Linda University as a cardiologist. She is the director of the Women's Cardiovascular Health and is the Early Career Chair for SCMR and uses her social media voice for education, inclusion, and diversity. And she is going to be talking to us about hypertrophic and other cardiomyopathies. Over to you, Purvi.
Thank you, Dr. Ashwath. Thank you, Iowa ACC and Dr. Ashwath for this kind introduction. This lecture is actually very special because I saw that Dr. Sivaram is speaking in the, he's speaking in the last session, and he was my program director at University of Oklahoma, and really all this learning goes back to him. He taught me the, first lessons of echocardiography. So I don't know if he's on or not, but really feels special to be in the same lecture series as him. I'd like to dedicate this, to a lot of people that are suffering in India. By the time I finish this lecture, 12 people would have died in India of COVID-19. So I'd take this opportunity and urge all of you, if you can be helpful in any ways. And I've just listed some organizations here for you to donate. So please help me on this mission that's on my heart, mind, and soul right now as I speak. But let's start with some questions. And what, I wanted to put the automated responses, but wasn't sure if we can get all the responses. So what I'll encourage all the fellows to do is probably use the chat function, and I'm going to keep the chat function open to see the answers. And kind of see what you guys have been thinking. So the first question is a 75-year-old male who has hypertension, hyperlipidemia, and CKD, and he has presented to the emergency department after syncope. He has described 2 weeks of fatigue and generalized weakness without any fever or chills. Also has some shortness of breath, which is progressive. He does have some NYHA class 2 symptoms, gets short of breath with one flight of stairs, and has a swelling in the feet, although he does not report any orthopnea. Otherwise his history is non-contributory. So these are the pictures. Let me just show you guys. So these are the pictures. So you have some echo images. So you can see that he has some LVAD, he has 2+ pitting edema. He's in 3rd degree heart block, and you have some strain images. His vitals are stable. His pulse is 33. So, he's quite slow, and he's in 3rd degree AV block. And these are the echo images for all of you. So I'll just give you a minute to kind of look at it one more time. So in general on echo boards, when I took them, I remember that every question you get 3 minutes to respond. So I'm gonna go next. So what's your diagnosis? If everyone can just use the chat function and tell me what you guys think. Okay, very good. Very good. So perfect. So all of you were able to identify. I guess we don't need this lecture, but so all of you saw that bullseye pattern that we see on the strain, and cardiac amyloidosis, which is 93% sensitive and 82% specific for diagnosis of amyloidosis. So this was a case of amyloidosis. Let's go for question 2. These are from EchoSep, by the way. So these are the questions that you get asked. So this same patient undergoes pacemaker implantation. He reports symptom improvement, but now he requires the further workup for cardiomyopathy. His SPEP, immunofixation, and free light chain assay are normal. So what do you think is the next imaging modality that is most reasonable in this case? If you guys can again use. Awesome. You have rockstar fellows, Mahi. on. Okay, so yeah, you are all right that, this is technetium PYP. That's the right answer because we have excluded the AL amyloidosis. And we know that echo is, quite suggestive of amyloidosis. And since you don't have the AL, possibility, then probably the next best step would be to use the PYP to see if it is transthyretin amyloidosis. Okay, let's go to the same. I want to see how many can answer this. So now he has on Doppler interrogation, his inflow velocity ratio is 2.8, his deceleration time is 120. And of course, we have made the diagnosis of cardiac amyloidosis. So what's his relative risk for intracardiac thrombus for given, all his echocardiographic findings, as well as particularly these this diastolic pattern, which is suggestive of restrictive cardiomyopathy. So it's a restrictive diastolic pattern. So let's see, can I get some responses? Okay. You guys gotta try it, even if it is wrong. So I need some more responses. Okay, so as expected, this is kind of all over the place. It's probably 30, 30, 30. Some of you said 2, some of you said 3. So actually it's 10 times. So whenever you have restrictive filling, it's actually the answer is 3. Your risk of getting an intracardiac thrombus increases by 10 times. And if you have atrial fibrillation on top of intracardiac thrombus, then it's 20 times. So this is again from EchoCep that I've taken this question. So keep that in mind. Let's go to another cardiomyopathy. So a 55-year-old woman, she's brought to ambulance out of hospital cardiac arrest, has cough and exertional shortness of breath, had VFib, responded to 1 round of defibrillation, intubated, brought to the hospital. Her vitals now are stable. Her EKG reveals non-specific intraventricular conduction delay. QRS duration is 136. Let's look at the, the echo. I skipped the EKG portion, but let's look at the echo. So I'll give you guys a minute to look at it. It's not circling. Okay. Okay, so what's the most likely diagnosis in this patient? Very good. Okay, so it is cardiac sarcoidosis. So, this patient is, let's go back to the history. So this patient is quite young, 55-year-old. It's a cardiac arrest, had VFib arrest, and there are very few things in a 55-year-old. Of course, we did not hear about any STEMI presentation. And its EKG reveals non-intraventricular conduction delay, which is quite possible with, cardiac arrest and sarcoidosis. And you have this cardinal sign of thinned enteroseptum, which is quite rare with, just CAD, just isolated involvement of the septum. So you have quite a thin enteroseptum. There is some wall motion in other parts as well, but patient has intraventricular conduction delay. So part of the wall motion, at least in this area, can be contributed to that. But this portion gives away the diagnosis. So this is a case of cardiac sarcoidosis. Okay, so let's get back to the, I was given the topic of hypertrophic and other cardiomyopathies, and I'll really try to do justice in 1 hour. It's an extensive topic. And what I've done is every time there are any huge teaching points, I have marked those slides with teaching moments so that if you want to take a snapshot or anything, you can take that. But I'll see how much I can cover given the time. And, I've also included multimodality imaging with this since I'm a multimodality imager. So I wanted to give you all a context of how echo is used, in this multimodality imaging world. So hypertrophic cardiomyopathy. So, let's start with the definition. So it's LV thickness of more than 15 mm or in one or more left ventricular segments by any imaging technique. The board question number 1 is, it's the most common genetic disease of the heart. It's transmitted autosomal dominant. The prevalence is not rare, it's 1 in 500, and it's the number 1 cause of death in number 1 cause of sudden cardiac death in young athletes. So these are the questions that you're going to see on your general cardiology boards. So in addition to echo boards, all these 3 are the board questions here. So remember the definition, remember that it's the most common genetic disease, remember that it's transmitted autosomal dominant, and it's the number 1 cause of sudden cardiac death in the young athletes. So what's needed for hypertrophic cardiomyopathy diagnosis is LVH, that's in any pattern. And what's not needed is obstruction. So, I think sometimes fellows they think that obstruction is absolutely needed for the diagnosis, and it's not needed. What's needed is LVH, and that LVH does not have to be the septal predominant. It can be anywhere. It can be in the lateral wall, in the inferior wall, wherever there is asymmetric LVH with that definition I gave you of more than 15 mm, if that patient can have HCM. The differential diagnosis, of course, is hypertensive heart disease, cardiac amyloidosis, and aortic stenosis. So on an average, 30% of the HCM are non-obstructive. So keep that in mind. 70% would have obstruction, 30% are non-obstructive. Again, these are board questions. So let's look at some definitions. So, of course, we all have heard the, the systolic murmur of HCM. It increases, increases during any of the maneuvers that decrease the preload, and it's attenuated by increasing the afterload. So the definitions of basal obstruction, when would you be able to call if there is an obstruction, is when you at rest you have more than 30 millimeters of mercury difference, and then anything less than that would be called non-obstructive. But you can you can have a physiologically provoked obstruction of more than 30, and that's called the labile obstruction. So this is from the ACC guidelines. So keep this definitions in mind. What would be named obstructive HCM versus non-obstructive HCM, and what's labile obstruction. So if physiologically provoked and still remains less than 30 millimeters of mercury, that still would qualify as non-obstructive HCM. And if it is physiologically provoked but goes above more than 30 millimeters of mercury, then it's a labile obstruction. So, of course, diagnosis, we utilize many tools to make the diagnosis, but today we are going to focus on, the echo findings. So let's talk about the obstructive HCM. So if we look at the obstructive HCM, it goes back to, there is this venturi effect in the LVOT that causes the LVOT obstruction because of the SAM. And then whenever SAM happens, in 20% of the patients, there is a mitral regurgitation that would happen because of SAM. And that mitral regurgitation typically is posteriorly directed. So we'll speak about mitral regurgitation in HCM. But remember that whenever the mitral regurgitation is happening because of SAM, it's posteriorly directed, although there can be other reasons of having MR in HCM patients. So this is an example of, HCM patient. You can see there is florid, quite prominent severe SAM, and that SAM leads to this posteriorly directed mitral regurgitation, and then there is LVOT obstruction. So this is how a classic patient with obstruction will present with. And this, of course, is tested on the boards, particularly with the M mode. So you can here see that during systole, so this is the systolic period, you always correlate it with the QRS complex. And during systole, there is systolic anterior motion right here of the mitral valve. So keep this in mind. This M mode has been tested for years on the boards, and that's something that you should keep in mind. So again, this is just another picture. So there are two things that happen. So of course there is SAM, and because of that SAM, there is posteriorly directed mitral regurgitation, and then there is LVOT obstruction, which generates the gradient, through the LVOT, and this is typically a dagger-shaped gradient, which you can see on the pulse wave as well as the continuous wave Doppler. So here is an example of pulse wave Doppler. Depending on how much the obstruction is, it may not be able to cover, in that Doppler range. And this is, here is the continuous wave Doppler. So this is, with Valsalva, it can go up further. So you stay in this view, which is typically a 3-chamber or a 5-chamber view in the apical segments. And then you try to see what the pulse wave as well as the continuous wave Doppler is. So again, just speaking about the M modes that are tested on the boards, there are two things that you can get tested. So number one is, of course, SAM, as we spoke about. Here is another example of SAM on this M mode. So it's seen best in the parasternal long axis view. Right here, we have shown that on the M mode, actually, because of this LVOT obstruction, you can also see this mid-systolic closure of the aortic valve due to reduced ejection. So again, that is seen on the M mode of the aortic valve, that you can get tested again. Same view, parasternal long axis. So you'll have like a notch in the mid-systolic, indicating the mid-systolic closure of the aortic valve, which is supposed to remain open during systole. So remember these two M modes for your exam. One is mitral M mode. You can see where exactly the M mode is going through, decide which valve they're testing you on, and then look at the systole as well as diastole. During diastole, the mitral valve remains open. During systole, the mitral valve should have this line, but right here you can see it's moving anteriorly towards the septum, and that's the that's the systolic anterior motion of the mitral valve. If the M mode is going through the aortic valve, right here you can see, and again, these are sometimes challenging, but if you know what exactly you are looking at, you'll be able to figure out. Then in a patient with HCM, you'll see this notch, which is indicative of the mid-systolic closure of the aortic valve. Now, I don't think that you will be tested, but I took this from EchoSAP. So, the degree of SAM, you can grade it mild, moderate, severe, depending on, how much the septal distance is from the mitral valve, right? So if it is more than a centimeter, it's mild. And if it is, less than a centimeter or a brief contact, then it's moderate. Or if it is prolonged contact for more than 30% of systole, then it is severe SAM. I think that we have some hackers or something. I'm seeing some, I don't know if the fellows are here and they can push out these people. So let's talk about the mitral regurgitation in SAM. So, in HCM. So this is again tested very much.
Sorry to interrupt for a second, Puri, but I think there's some annotations. So whoever the audience, if you can please refrain from the annotations or delete them, that would be great. Thank you. Please go ahead, Puri.
Thank you. So I think this is a very commonly asked question. Again, on boards, both on the general boards as well as the echo boards. I wanted to take time and just explain all of you what exactly this means. My fellows love this slide, but remember that you can have many systolic events happen at the same time, and the boards will test you on this, and you need to identify what exactly you are looking at, right? So, particularly in patients with HCM, when you see this butterfly appearance, you remember that, it's a patient with HCM because you have LVOT obstruction and mitral regurgitation happening at the same time. And again, the first thing you want to look at is the direction where exactly that continuous wave Doppler is going through, right? Because as I told you, if MR is happening because of SAM, then it would be posteriorly directed. So look exactly where that continuous wave Doppler is going through. The next thing you're going to look at is what your shape is of the, signal, the Doppler signal that you are looking at, right? So if it is parabolic, right, like shown here, it's probably mitral regurgitation and you have contamination in your LVOT gradient. But if it is dagger shape, then you're probably dealing with LVOT signal. So just keep this in mind. And then, the other thing to remember is that you can also get tested on what is fixed aortic valve obstruction, i.e. aortic stenosis, versus what is mitral regurgitation, right? So again, remember that mitral valve begins with mitral regurgitation begins with mitral valve closure and ends with mitral valve opening. So it literally will start the minute your QRS complex starts. So it will start without any delay, while aortic signal will happen when the aortic valve starts. So remember that there is this gap, also known as isovolumic contraction, when the aortic valve is closed. So you're going to have that little bit of gap where your aortic stenosis signal would not start at the peak of the QRS. There is a bit of a delay. So remember to, just keep these Doppler signals in mind, along with, in relationship to the QRS complex, because on board sometimes you may not be given any other information apart from a Doppler signal, and you may be asked the question. So just imprint this picture and see the difference between aortic stenosis, mitral regurgitation. Tricuspid regurgitation, of course, would be on the right side, and the HCM, which is more of a dagger-shaped pattern. So dagger shape versus parabolic, immediate start at the QRS complex versus a delay with isovolumic contraction. So mitral regurgitation in HCM can be because of many, many reasons, right? So, these patients don't tend to have necessarily, the exactly normal mitral valve. But the thing to remember, for all of you is that, there is geometrical distortion of, the entire, PEP alignment and how PEPs are organized in the heart in these patients. And then, of course, SAM is there. SAM will contribute to the posteriorly directed mitral regurgitation jet. So SAM is seen in many patients with HCM, but out of those patients, mitral regurgitations happens probably around in 20% of the patients, right? So remember that. Then there can be mitral valve prolapse, there can be MR related to the VT, there can be MR related to the pacemakers, or there can be MR related to the LV dilatation that can happen in end-stage HCM. So I think for boards, the most important thing from this slide I want you all to take is that the SAM-related MR, again, is posteriorly directed. That's when you think of SAM, you think of HCM. If it is central or anterior related, then probably the MR etiology in that HCM patient may be different in real life, but I don't think that you will be tested on other, other direction MR on your board. So just remember SAM, HCM, posteriorly directed mitral regurgitation, and that's the mechanism. So this again you can use in your real life as well as on the board. So this is an internal check for LVOT gradient. So we all know that the MR peak gradient would be equal to LV systolic pressure minus the left atrial pressure. So basically the LV systolic pressure would equal to MR peak gradient plus the left atrial pressure. And if you then have systolic blood pressure, then and you can use this equation because LV systolic pressure minus the LVOT gradient would come down to a systolic blood pressure. So it's kind of like an internal check where you can check if your LVOT gradient that you are getting on the echo is accurate or not. And if not, then you can go and scan yourself and try to find that LVOT gradient that matches with your the MR signal as well as the blood pressure curve. So feel free to take snapshot of this slide because I know it may get confusing, particularly since right now, but just think it over afterwards, and just make sure that you understand these equations. So let's take a case. So it's a 35-year-old male presented with cholecystitis, post-operatively after laparoscopy, developed tachypnea, and EKG is done. And this is his echo. So you can see that there is quite a bit of asymmetrical septal hypertrophy. And again, trying to see if there is any SAM or if there is any mitral regurgitation, and you can see that you don't see much mitral regurgitation. Maybe there is some crowding here, so you can't figure out if there is, if there is SAM or not. So I think I have a M mode on this patient. Let's see. Okay, so here is the M mode, and you can see again there is septal hypertrophy, but in diastole the mitral valve opens, in systole it remains closed, so there is no systolic anterior motion of the mitral valve. So this is a normal M mode of the M mode of the mitral valve, and so based on this you can pretty confidently say that there is no systolic anterior motion of the mitral valve. So perhaps you are not going to find that much of a LVOT gradient, although patient does have asymmetrical hypertrophy, which we can very well see in multiple pictures. So just another picture here for you. Okay, so sure enough, you already guessed this, that there won't be much gradient, and you don't have much gradient. There is some diastolic dysfunction, pseudonormal pattern, and you have, this is the pulmonary vein pattern, and again, not bad. So it's a young patient, comes with cholecystitis, develops tachycardia. You have figured out now that he has, HCM based on this echo, and at least at rest, you don't have, any LVOT gradient. So now you're going to do the maneuvers, and you're going to figure out if with maneuvers you are able to provoke the LVOT obstruction. This is just a treatment of the LVOT obstructions. I'm going to skip this. So he actually did not have any provoked gradient. And then he was also given treadmill stress test, and he did okay on treadmill. On Holter, he had 2 episodes of non-sustained VT. Lasting for 3 seconds, and at the rate of 162 beats per minute. His septal thickness was 2.1, the LV mass was increased, his PASP was 37. Basically this patient has HCM. We have established that it is non-obstructive HCM, and he has VT, so he was given cardiac MRI. So just quickly showing you guys cardiac MRI on this patient so that you get some multimodality context. And I have some slides on MRI, and then we'll go to the other cardiomyopathies. So you can again see that the extent of the LVH is nicely seen here on MRI. And again, we saw that on echo as well. So this is one of those lucky patients where we can see it well, on both the modalities. And this is just, I think, same picture. Let me just go to the money shot. I'm gonna make sure we cover everything. Okay, so this is the late gadolinium enhancement. So I'm not sure how many of you are familiar with MRI, but this donut shaped, after we give the gadolinium, this donut of the myocardium should be dark. And you can see that there is all this patchy whiteness, and that is basically the delayed enhancement. So right here again, it should be in the form of quite dark myocardium in the LV, and you can see see that in the areas where he has, hypertrophy, he has quite a bit of delayed enhancement. So his delayed enhancement percentage was, I think, around 20%. So either you take echo or you take MRI, there are HCM phenotypes that one has to recognize. So, we all know the apical version, the spade shape. So remember that concentric HCM that you probably will see quite a bit also and won't miss. Basal septal is, can be very tricky because sometimes these patients can be labeled hypertensive. So basal septum is this one. This is the reverse curve. Apical we already discussed, and then the mid cavity is very interesting because it can be associated with distal apical aneurysm because of this obstruction that is happening at the level of the mid cavity. And then the lateral, which we should not forget, where there is lateral predominance or the asymmetric hypertrophy of the the lateral wall. So remember these HCM patterns. In my opinion, on boards you will be asked about the apical variant as well as the basal septal with obstructions and all the questions about SAM and mitral regurgitation, as I told you. So typically, we do MRI in these patients to, kind of figure out if there is HCM truly, or is there any to confirm the diagnosis of HCM in these indeterminate patients, and then also to evaluate whether it is obstructive or non-obstructive, and what's the pathophysiology of obstruction in those difficult patients where you want to send the patient for further management, and you want to make sure that the surgeon or the the interventional cardiologist takes care of the obstruction exactly where it is happening. So to figure out the pathophysiology, sometimes echo can be challenging, and you will send these patients for MRI. And of course, you want to see the late gadolinium enhancement, since there is prognostic data with LG patterns. And then there are some echo blind areas that I just wanted to speak about briefly. Echo blind areas can be in the, the RV, the lateral wall. Sometimes, it can miss the, the very obvious SAM that may be happening at the PEP level. And then aneurysm can be missed, and then the crypts can be seen on the MRI, which is pathognomic. If it happens in more than 3 bunches, then it's pathognomic of the HCM, particularly in the patients who have family history of HCM. So just be careful with calling the diagnosis of no HCM, particularly in the patients who has family history, without advanced imaging. And there is very well known the discrepancy of the LV thickness between echo and MRI, and I won't go into details, but I just want to show you all this phenomena. So typically, the moderator band insertion can happen high up in the septum, and sometimes this demarcation can be very easy to figure out on advanced imaging modalities like MRI, but on echo, it can be included in the in the measurement of the basal septum. So one has to be careful, because guidelines actually use the basal septum diameters and overall thickness of the myocardium in evaluation for ICD in these patients. So be careful, particularly for this area, and again, that is RV moderator band inserting high up into the septum, which can be mistakenly and included in the calculation of these patients. So again, just giving you some examples. So, of course, not everyone has the best echo pictures. And of course, we don't have time to go back and get the best echo pictures, but just wanted to give you guys some context, when it is off axis, or when there is inclusion of the RV trabecula, you can include, what's not needed, particularly with that moderator band, and underestimate or overestimate that area. I'm just going to go with this, and then, again, where to measure. Sometimes it can be tricky with poor acoustic imaging. And then just one word, there's LGE is very helpful for the risk stratification. So presence of the LG, unfortunately, is in 50% of the patients with HCM, but you're not going to go with, ICD in all these patients. So you want to see what the, clinical context of the patient is, what other features the patient has, but the LG more than 15% matters. This is associated with composite events similar to the myomectomy and in non-obstructive subgroups. So even in these patients, after the treatment is done, the surgical or the interventional treatment is done, the percentage of LG, even after the treatment, matters, showing that the fibrosis has, way more role to play when it comes to overall cardiovascular events in these patients than just the, than just the other features that we care about. So this is a board question. You will be asked on athletic heart versus HCM. So again, keep this in mind. So typically, the athletic heart will respond to the detraining. These patients would have supernormal exercise capacity, and there is, dilatation involved, which is rare to see in HCM patients. And there is no, these patients typically don't have any scar tissue on MRI. So that's another way to differentiate the two. So these are teaching moments, so keep in mind, and very much asked on the board. So I told you all that 30% of the HCM patients carry the diagnosis of non-obstructive HCM, and in spite of low annual mortality rate, they are still, they have very high rates of adverse cardiac events, and it's equivalent to obstructive HCM. Make sure that if you are asked what to do next, make sure to provoke symptoms, provoke gradients, as well as subject these patients to exercise stress echocardiography to see, where exactly those resting gradients end up with exercise. So let's take a case now. So this is a 60-year-old male, complaints of heart racing, mild chest pain, comes to hospital. He was discharged after a brief observation and, was found to have VT afterwards, and then comes back to the cath lab, and cardiac cath is performed. You can see that on EKG, he has quite evident T-wave inversions in V4 to V6. So the diagnosis, of CAD was of course considered, and patient, given his VT, he was sent to cath lab. He has VT, looks monomorphic VT. And then, he gets the echo, and you can see that, he has this outpouching of the apex that is happening here. So this is that mid-ventricular type that I had shown you all in the phenotypes. So mid-ventricular leading to the outpouching of the apex or the aneurysm of the apex. And I just wanted to show this case. We send the patient for MRI, and you can see the aneurysm again very well. Even on the MRI, we saw it very well on the echo as well. So you can see that the obstruction is, in this case, is happening at the mid-ventricular level. So this is mid-cavity HCM associated with a very thinned out and aneurysmal apex. You can see it both in the 4 as well as in the 2 chamber. So this patient, given his monomorphic VT, was sent for VT ablation. Before that, let me show you the LGE. So you can see that there is late gadolinium enhancement. These areas are supposed to be dark, and you can see that as you come to the apex, the area is completely bright. So this is, kind of like a transmural infarct pattern, but that's what happens in these patients because of the mid-cavity obstruction. There is subendocardial ischemia that slowly advances, and these patients develop the, kind of like an infarct pattern in the apex, which is associated with aneurysm. And that's why you have this really transmural infarct that you can see in the apex. So this is a 3-chamber view. I hope you all can appreciate. This is the aorta, this is left atrium, this is left ventricle, and you have this really scarred out apex. This is a 4-chamber view, RV, LV, RA, LA, and then you again have this, pretty bright apex, 2-chamber view, quite a bright apex, and these are the short axis views. And again, it should be normal like this all the way down, but you see that there is a apical infarct. So this patient was sent for ablation, and they were able to ablate this arrhythmia. But I just wanted to, just show you all, because there are two things that are associated with patients, that have mid-ventricular cavity obstruction with apical aneurysm. Number one is they have more arrhythmic events compared to the other patients, and then they have more thromboembolic events. So guidelines actually recommend, subjecting these patients for anticoagulation. I forget the level of evidence. I think it's 2A, but I may be wrong on that. But these are the two things that you should remember with the apical aneurysm. And then just 1 minute to kind of spend on anomalous papillary muscle insertion. So these patients can have, the apical insertion of the PEP, or they can also have the PEP insertion directly into the anterior mitral valve. Let me see if I can play this again, but you can see that the PEP, directly inserts into the mitral valve. And this is what I meant when I was saying that the geometrical, alignment in these patients are quite disturbed. And, there can be many mitral valve abnormalities that can be seen, which can be contributing to left ventricular outflow tract obstruction. This particular pattern can be seen in 10 to 13% of the patient. And why it's important to identify is because when these patients go for surgical treatment, you need to exactly tell the surgeon what they should be doing. So I had a case on myomectomy, but I think I took it out so that I can pay some attention to other cardiomyopathies and then have some time for the question answer. So the take-home points for HCM is it's the most common genetic disease, is the most common cause of sudden cardiac death in young athletes. Number one cause of sudden cardiac death in young athletes. And the definition, remember, it's more than 15 mm. 30% of these patients will be non-obstructive. The CMR, the LGE, 50% of the patients will have late gadolinium enhancement on cardiac MRI. And that's why it has not made it to the guidelines yet with a strong recommendation, but more than 15% of the late gadolinium enhancement matters. And remember, for boards is the general cardiology boards, the guidelines for the ICD implantation and its weakness, just review it. For echo boards, it may not be that much relevant. So let's go and speak about cardiac sarcoidosis. So cardiac sarcoidosis, the echo findings, if we look at it, there is, of course, increase in the LV thickness that simulates the LVH. There is LV dilatation. There may be wall motion abnormality that do not correspond to the coronary distribution. So the typical thing that you would see in these patients is, the septal thinning. You will have ventricular aneurysm, like, in this patient, the septum, the basal septum is quite thinned and and aneurysmal, and then the right ventricular dilatation and hypokinesis. Sometimes these patients can be mislabeled as ARVD, but that's why it's very important to thoroughly look at the imaging modalities and make the diagnosis because ARVD and sarcoidosis can be sometimes can be confused, particularly on the initial imaging modalities. And remember the rhythm abnormalities. There are very few things that can lead to AV block in young patients. So cardiac sarcoid comes number one, and the second one is the Lyme's disease. So remember that clinical context that you'll be provided on the boards, and keep everything in mind when you are reviewing that case. So let's see. I have some slides on ARVD as well, which I'd really like to finish, but this is another example. So here you have a clear-cut aneurysm of the basal septum, and again this can also involve the not just the basal septum but also the inferior wall. So this is infroseptum aneurysm, this is the inferior wall aneurysm, and you can see this on the 3D right here. So just keep an eye on the planes that you are scanning this patient. Sometimes you when you're scanning on echo, you really need to bring these abnormalities up depending on the cut of the echo, you may not be able to see it. So let's go to the stages. So this is a very nice paper from Ron Blankenstein that I'd highly encourage all of you to look at. But basically, the spectrum of the echocardiographic findings really, change from the normal to the focal aneurysms and then to the dilated cardiomyopathy. So actually, sarcoidosis may come in the restrictive cardiomyopathy and then later on in dilated cardiomyopathy, depending on the stage the patient is in. So remember that. So at this stage, it may be, featuring some of the restrictive cardiomyopathy patterns on Doppler, etc. But then the burnt out sarcoid would be dilated cardiomyopathy. And in fact, a lot of these patients remain undiagnosed. So a lot of these patients, are found when the heart transplant is done or the autopsy is done. So there's data about, GLS correlating with the worse outcomes in these patients. So strain is important in any of the cardiomyopathies we took today, and we are going to speak more about strain in amyloidosis. So just keep this in mind. And then the thinning of the interventricular septum on transthoracic echo also has been associated with worse outcomes. So keep that in mind. So the limitations of the transthoracic echocardiography in sarcoidosis is, of course, that only 25% of the positive CMR and FDG PET have positive echoes. So echo, unfortunately, has less sensitivity, and that's why the negative predictive value is only 32%. So particularly when you look at the early or the localized mild cardiac sarcoidosis, it has extremely low sensitivity. And I just want to show you guys a couple of images on MRI. So in my opinion, and there is a lot of discussion on this, but MRI is the first choice of test. And that is because, it gives you the diagnosis, and the extent of the delayed enhancement has been associated with the incidence of arrhythmia as well as the ventricular function. And it's really, superior to any other parameters. The delayed enhancement, the late gadolinium enhancement is superior to any other parameters. And it's an independent predictor of events in these patients that are quite sick. So really quickly, again, the normal is you should see the dark donut, then there can be focal involvement, then there can be multifocal involvement, and then there is extensive delayed enhancement, and this is burnt out sarcoid. So, the spectrum of the findings really depend, both with echo and MRI, where exactly that patient is. And just one slide on the FDG PET. So FDG PET is utilized to figure out whether that patient has, the patient that has been diagnosed on echo and then MRI with positive sarcoidosis, at what stage of disease they are at, so that you can decide whether to treat that patient or not. And this goes back to if they have, positive FDG, in these patients. So here again, this is the spectrum of the findings that you can have. So we do perfusion as well as FDG both. And FDG kind of detects the cellular metabolism on these patients, and perfusion tells you at what stage of sarcoid they are at. So if you have perfusion abnormalities, this patient is really at the end stage sarcoid, and there may not be any option for medical treatment, and these patients probably would benefit more from the advanced heart failure management like LVAD and transplant. But in initial stages, you can have just focal involvement when there is no perfusion defect, but you have FDG uptake, meaningly this is the inflammatory area, and you can go and focus your medical management efforts on these patients and then repeat the PET. We actually published a series of patients from my fellowship site, UCSF, and we showed that you can actually see the progression in these patients at every 3 months by doing every 3 months PET, and kind of showing at what if they have improvement because of medical management, which is typically immunomodulators and steroids. So just a quick word on that. And so, the diagnosis of sarcoid, it's, very interesting, right? So echocardiography kind of suggests you this pool of patients where you think of sarcoidosis diagnosis, but again, because of the poor sensitivity, to be confident of your diagnosis and to make sure that you're not missing, particularly in a patient, a young patient with classic clinical findings of sarcoid, you have to go to cardiac MRI to make sure that you're confident. And you cannot use PET at that stage because PET unfortunately has quite high false positive rates. So you have to be careful making the diagnosis alone based on PET. And then after cardiac sarcoidosis, you'll go to PET and you'll decide whether that disease is active, where you can give medical management, or it is burnt out sarcoid end stage. And then in that case, you will send that patient for advanced heart failure therapy. So I think that was the last slide on sarcoid. And I know I'm at 1 hour, but I started 20 minutes late, so I'm going to take 20 minutes more. So amyloidosis. So typically the findings of amyloidosis would be LVH and RVH, there can be thickening of the interatrial septum. There can be biatrial enlargement. There can be involvement of the valves where the valves are quite thickened. There's concentric hypertrophy and speckle pattern and the bullseye that you all were able to identify in the question that I showed. Remember that there's 93% sensitive and 82% specific for amyloidosis, and these are pretty good numbers for non-invasive imaging. So in my opinion, every patient where you suspect amyloidosis should be subjected to strain pattern. And then the restrictive pattern, remember the numbers on the restrictive pattern, because sometimes you may be given the E and the E by A and the E prime numbers without showing you the image. So it may not, automatically you may not register. So remember these numbers that are utilized for diagnosis of restrictive cardiomyopathy, because it can be just that thing in your question stem. So again, looking at the echo, just, speckled pattern, as I told you all, there is LVH, RVH, mitral inflow, look at the mitral inflow, look at the pulmonary vein Doppler, diastolic predominant, and then the tissue wave Doppler, which is quite low in numbers, very, very classic restrictive. So remember the numbers, imprint these images, because this is classic amyloid, and I'm glad you were all able to identify. And then, you have the bullseye pattern, when there is apical sparing, and this, as I said, is very good for the diagnosis. So keep that in mind. So I just wanted to spend 1 minute on this slide, since strain imaging may be tested on all of your boards. So, so the A1 to A4, you can see that you have apical sparing, in a nutshell, with different examples. And this is all examples of cardiac amyloidosis. So remember that the apical sparing can come in all, types and flavors. And then you have, this B1 and B2, that's hypertrophic cardiomyopathy. So remember that, because this can be tested again on your boards. And then this C1 and C2 is aortic stenosis. And we all know that the, aortic stenosis, the longitudinal strain can be quite patchy and different. So you don't know which pattern it's going to take. So remember that. If it is not specific, looking like this or this, it's probably aortic stenosis, because these are the three conditions that are tested quite a bit for LVH differential diagnosis on board. So just imprint these findings again, for the boards. So let's talk a little bit about arrhythmogenic right ventricular cardiomyopathy. So really a new diagnosis. We have not, literally this was, 2 years before I was born. So, it's a very new diagnosis. And, initially this is the initial paper, and you can see that they were trying to think what exactly this is, where, you have these aneurysmal dyskinesis of the right ventricle. And this was really done on 34 patients. So think about how, literature gets started based on case reports, right? So it's pretty humbling, but it's a genetic cardiomyopathy. The prevalence is close to 1 in 5,000. 20% risk of sudden cardiac death, particularly in young individuals. There is a male predominance, so remember that. And the pathophysiology is that there is, fibrofatty replacement of both RV and LV. So we used to call it arrhythmogenic right ventricular cardiomyopathy, but now it's ACM, arrhythmogenic cardiomyopathy. And that's because now we have recognized that it can involve LV as well. And I have some case examples for you all. So keep that in mind. So unfortunately, the revised criteria are quite old, 11 years old in 2010. So they did not include, there was not much research done at that time, and the LV findings were not included. But these are the findings that can be tested on your echo. So again, I'm not going to spend much time, but make sure that you all look at this carefully. What exactly it is, but in general, remember that there needs to be RV akinesia, dyskinesia, or aneurysm. So keep that in mind. Global hypokinesis of RV may not be, a classic case of ARVC, particularly on boards, although it can happen in real life sometimes. And then you want to remember the diameters as well as the fractional area change, which will be on your text. So this is example of one of these patients, and you can see that the RV is quite dilated. There is some involvement, and again, these are tough patients to diagnose, on echocardiography, depending on the acoustic windows. But right here, you can see that there is not much movement in this area. And then again, you can appreciate in this view, the short axis view. So just a real quick, so it can have RV phenotype, it can have biventricular phenotype, and it can have predominant LV phenotype. So I just wanted to show you all. So this patient met the criteria with RV, but you also can see this linear delayed enhancement in the LV. And, this is a patient with biventricular phenotype. The serration on the MRI, particularly in this area, has been associated with arrhythmogenic right ventricular dysplasia. So keep that in mind. Just wanted to show you this triangle of dysplasia that is responsible. Of course, you all are going to be tested on epsilon wave. So look that up, what exactly that is. But it's this notch that you see. And it's this area of, RV inflow that is going kind of out to RV outflow that is responsible for that is actually the classic area and the frequent sign of dysplasia. And then now, the latest literature, this was a paper in 2017, it actually, that dysplasia triangle has been expanded into quadrangle of dysplasia to include the RV findings, because that's the area that gets involved typically in the patients with biventricular involvement. So this is a echo finding of a patient with biventricular involvement. And you can kind of see that, we see this mid-ventricular, mid-ventricular mid-wall enhancement in the echo, in the MRI. And you can kind of see that, these patients, again, here, even on echo, when you give contrast, it's not absolutely normal. So this is, again, this may be that patchy area that we see on MRI, but this is one of the examples I wanted to share with you all. So this is really quickly another case that I just wanted to show you. So you can see the area of dyskinesis, kind of this area, how it's outpouching. So this was a quite young patient. She's actually my clinic patient who has despoplakin gene positive and has quite a bit of PVCs. So I think I have one slide on Takotsubo, and then I will be done. And then if there are any questions, I'm happy to take them. So Takotsubo, again, it can be tested on board. So remember the mid and the apical akinesis, classically it extends beyond the distribution of LAD. Remember that 1/3 of the patient will also have RV dysfunction, and keep in mind that there is a mid left ventricular Takotsubo, so mid-ventricular Takotsubo and reverse Takotsubo pattern or inverted Takotsubo pattern. So just make sure that to identify the areas that are akinetic, whether it is apex or whether it is reverse of apex, then it may be reversed cardiomyopathy. So keep in mind the clinical context that is given to you. And remember also that sometimes because of the hyperdynamic basal segments, and particularly with the the classic Takotsubo, you can have left ventricular outflow tract obstruction and SAM and MR in acutely sick patients in CCU. And this can be one of the vignettes that can come either on your echo boards or general cardiology boards. So don't label them as HCM. Look at the entire picture. Just like, anterior MI sometimes can lead to this pattern, just identify why the SAM is happening, what the wall motion abnormality is. So I think that is my last slide. Let me see. So the conclusion is echocardiography is definitely the first line imaging modality for diagnosis of cardiomyopathy, but we should we should be aware of the strengths and weakness of every imaging modality and use it to the advantage of our patients to make the correct diagnosis and offer them the right treatment. So with that, I thank you all for your attention, and I'm happy to take any questions if there are any. Severe MR, can we have severe MR due to Takotsubo? So again, as I mentioned, I think it depends on the most common that, as I described, sometimes you can have SAM and you can develop MR. And that's why when you are a fellow in CCU and you're called to take care of that patient, you have to be very careful in what vasopressors you are offering that patient, etc. But yes, it can happen. You have to look at the overall context of the patient.
Thank you very much, Purvi. That was a very comprehensive and excellent review. I appreciate your contribution to the lecture series. And as Purvi rightfully said, please keep India in your thoughts and your prayers. Terrible situation right there even now. So hopefully things will turn around, but please keep India in your thoughts and prayers. I'll move on to our next speaker, Dr. Frank Corrigan. Dr. Corrigan grew up in Atlanta and completed his medical school at Johns Hopkins, followed by internal medicine residency, cardiology, interventional cardiology, and advanced cardiac imaging fellowship at Emory. He started at Wellstar, 11 hospital system in Georgia in 2018 as an interventional cardiologist and advanced cardiac imaging specialist, where he works as part of the structural heart team and is helping build their coronary CT and FFR CT program. And he's going to be talking to us today about echocardiography in systemic diseases. Over to you, Frank. I think you're muted. We cannot hear you yet.
All right. Hi, everyone. Can you hear me now?
Yep, all good.
Okay, let me get this set up. Well, I'm excited to be here and excited to be here virtually. What we wanted to talk about today is echocardiography and systemic disease. Some of this may be a little repetitive, but that'll serve as reinforcement. But I'm going to try to keep this case-based. If there's any question throughout, just feel free to ask. But again, thanks for having me. So I have no relevant disclosures. Let me just do my thing with the PowerPoint here. Okay. So echocardiography and systemic disease. Systemic diseases resulting in cardiac dysfunction are unusual. However, specific patterns of cardiac dysfunction can provide clues to underlying systemic diseases. And echocardiography also often serves as a marker of a disease, which then allows us to investigate further. It can also be used for prognosis. So our first case is a 71-year-old man with HIV who presented with syncope. He said that he woke up to use the restroom, felt dizzy, developed nausea, and then collapsed. He woke up on the floor with a bloody nose. So certainly had a traumatic syncope, but people that wake up at night and collapse, that can be for all kinds of different reasons. Here was his EKG, and we see that there's low voltage in the limb leads, but relatively preserved voltage in the precordial leads. Here's his chest X-ray, which shows some pulmonary vascular congestion. And then here's his echocardiogram. So certainly his echocardiogram's abnormal, and what we see is that there's thickening of both the interventricular septum as well as the lateral wall. And in our short axis view, we can see there's pretty much diffuse thickening. Also a good bit of mitral regurgitation. So thoughts: this patient has severe concentric LVH, a small pericardial effusion, moderately reduced LV systolic function. There's severe left atrial enlargement. If you look at the left atrial volume index, it's 53. And then there's diastolic dysfunction looking at the mitral inflow. So this patient has a restrictive cardiomyopathy with hypertrophy as well. And there can be multiple etiology of this. In this case, as we heard from the last lecture, strain can be very helpful. This patient has overall reduced global longitudinal strain that preserves the apex. This is a characteristic finding of cardiac amyloidosis. And this is a diagnosis that's being increasingly recognized primarily because now we have therapies for it. There are new therapies for the TTR amyloidosis. Patients usually present with symptoms of right heart failure, but syncope is actually a fairly common presentation as well due to frequent bradyarrhythmias or advanced AV block, which was the case in our patient. Strain can be very helpful. Overall, there's a reduction in global longitudinal strain, but there's a pattern of relative apical sparing. Some people call this the cherry on top. I had a resident say it looked like a Santa Claus hat over around Christmas. So whatever you want to call it, but there's a pattern of relative apical sparing, and it's a pretty good, it's a pretty sensitive finding for the diagnosis. Other modalities are generally confirmatory. Cardiac MRI shows diffuse delayed gadolinium enhancement. This is from our patient as well. There's increased extracellular volume. There's an inability to null the myocardium, which is, I'm not going to get into MRI physics, but another confirmatory test, which is more specific for the TTR variety, is bone tracer nuclear medicine studies, where the technetium labeled pyrophosphate actually localizes to the heart. So normally this labeled technetium goes to the bone, but in TTR amyloidosis, it localizes to the heart, and there's a grading scale for this. But these are two images from the patient that we described as pretty classic for amyloidosis. So this is another patient. This is another patient that also has concentric LVH, a small pericardial effusion, not too dissimilar from our amyloidosis patient. But this is just a patient with ESRD. So the reason I bring this up is we spend a lot of time talking about LVH, concentric LVH, and thinking, and there are always all kinds of different causes of these things. So it's important to keep an open mind when you see left ventricular hypertrophy. So there are many different causes of restrictive cardiomyopathies. There are genetic diseases, renal disease, as we just showed, hypertrophic cardiomyopathy, hypertensive heart disease, which is very common. If you see a patient like this, it's always important to get their history of hypertension, amyloidosis, and clinical history is key. Strain is often very helpful in this group of patients. Certainly amyloidosis has a characteristic pattern, but apical hypertrophic cardiomyopathy has almost a reverse pattern of amyloidosis. Concentric LVH in the setting of hypertensive heart disease or end-stage renal disease has a very different pattern. The strain pattern can sometimes help sort this out. Moving on to our next case. This is a 74-year-old lady with prior breast cancer and a recent COVID-19 infection. I thought it'd be important to include COVID-19 in this talk, who presents with worsening dyspnea over the past week. Her dyspnea acutely worsened and was accompanied with nausea, vomiting, and chest pressure, which caused her to present to the ED. And so here's her EKG at presentation. Below, here's her EKG 1 month prior. You can see certainly her heart rate's a little faster, but she does have kind of an incomplete right bundle branch block, which wasn't there before. And if you look in lead 1, There's an S wave that wasn't there before. The labs at presentation, she has a mildly elevated troponin T and an elevated internal proBNP. Here's her echocardiogram. You can see just looking, the RV is certainly larger than the LV. And there also is a specific pattern that we'll talk about. Here's the short axis view, and you can see that there's septal flattening in diastole, suggesting a right ventricular volume overload. And then here's our tissue Doppler and our TAPSE. The S prime is reduced, suggesting right ventricular systolic dysfunction. And the TAPSE is also reduced, suggesting the same thing. So this patient has a dilated right ventricle, reduced systolic function, but interestingly has the apex appears to be preserved. And this is a distinct pattern known as McConnell's sign in the setting of an acute pulmonary embolism. These patients have, this is typically when people have a massive or submassive pulmonary embolus, you start to see right ventricular dysfunction. But this is a distinct pattern where there's near akinesis of the mid-free wall, but normal motion of the apex. And here's our patient's CT scanning. You can see that there's a saddle pulmonary embolus. This patient actually went for invasive pulmonary embolus therapy, which I know is a little bit controversial, but as we're starting to recognize which patients may benefit from that therapy further, echocardiography can play a key role. And 6 weeks later, you can see this patient's RV is normalized. So this patient was recently diagnosed with COVID-19. This was about 6 weeks after their COVID diagnosis. And as we've all learned, COVID has a variable effect throughout the body. Many common cardiac complications include myocarditis, stress-induced cardiomyopathy, myocardial infarction. We've seen as I'm sure everybody has, a handful of patients who have MIs in the setting of COVID, and then right heart failure. This is an MRI demonstrating edema in the setting of myocarditis. The echo findings of COVID are variable, and we're learning more every day. But in a review of 100 hospitalized patients, nearly 40% of the patients in the hospital had some sort of RV dilation or dysfunction. Left ventricular dilation, left ventricular diastolic or systolic function was less common, but certainly could be present. Patients with elevated troponin were more likely to have abnormal echoes, which I think makes a lot of sense. But patients who had both elevated troponin and abnormal echoes had a higher rate of mortality. From a recent review in JACC, looking at patients who have cardiac injury in the setting of COVID-19, as we said, it could be lots of different things. Most common was right ventricular dysfunction, followed by LV dysfunction, global LV dysfunction, diastolic function, and then pericardial effusion. I feel like we see a lot of patients in clinic that have kind of pericarditic type symptoms, and we do an echo and then they don't have an effusion. I find it interesting that that pleural effusions were a little less common in this study. But as we described, patients with myocardial injury, in other words, elevated troponin, and echocardiographic abnormalities had a higher rate of mortality, which I think makes sense. It's saying that this virus has caused more stress on the patient's system. So here's another patient. This patient has, as we saw in our previous case, a dilated right ventricle. Though it looks like the RV systolic function is relatively preserved, and the RV free wall tends to move a little better than our patient with the PE. This is a patient, a 54-year-old man with hemoglobin SC disease, which is a variety of sickle cell anemia. Sorry about the video here, but this patient also has flattening of the interventricular septum, which is characteristic of RV volume overload. This patient has right heart failure, with pulmonary hypertension. And the reason I bring this up is we saw a patient with acute cold pulmonality, which is what the patient was with pulmonary embolus. But oftentimes we see a dilated right heart on echocardiography, and it should prompt us to look a little further to try to understand why this is happening. The case I just showed of the patient with sickle cell anemia has pulmonary hypertension due to their sickle cell disease. So as cardiologists, we often uncover systemic diseases when we just do an echo. It's important to keep in mind that there are multiple different types and causes of pulmonary hypertension, and sometimes echo with RV dysfunction can be the beginning of the evaluation. Looking at the WHO classifications, there are 5 groups. Group 2 is left heart disease. Group 3 is due to an underlying lung disease. Group 4 is our chronic thromboembolic pulmonary hypertension. And then group 5, which I think is where we classify our sickle cell anemia, is kind of this unclear mechanism, but causative of pulmonary hypertension. All right, moving on to our third case. This is a 72-year-old man with hypertension, hyperlipidemia, and type 2 diabetes who also had a history of sudden cardiac death. Obviously, he survived, but here's his echocardiogram, and you can see this patient doesn't have any hypertrophy, but the LV systolic function is reduced. Here's his apical 4 chamber, maybe a little bit of hypertrophy, but overall, the main finding here is that LV systolic function is reduced. So this patient went on to then have a cardiac cath, and the coronaries were normal. Talking to the patient a little further, we uncovered that he had a history of pulmonary sarcoidosis. The patient underwent MRI, which showed patchy delayed enhancement in the mid-myocardium that was not in a vascular distribution, and we thought represented cardiac sarcoidosis. Cardiac sarcoidosis can have multiple different types of patterns. The main thing is just to keep it in the differential. PET FDG can be helpful. So cardiac sarcoidosis results from non-caseinating granulomas infiltrating the myocardium and can cause regional wall motion abnormalities in unusual distributions. Oftentimes these patients can develop heart block or even develop sudden cardiac death due to arrhythmias. Interestingly, the left ventricular free wall is most commonly affected, and the interventricular septum is affected about 3/4 of the time. The atria can be affected as well as the right ventricular free wall. The spectrum of echocardiographic findings can be from normal to severe dilated cardiomyopathy. But what's interesting is often these patients develop focal aneurysms where there has been burnout disease. The spectrum of gadolinium enhancement on MRI can be from normal to extensive late gadolinium enhancement. Usually the amount of gadolinium enhancement corresponds to the severity and burden of disease. FDG PET can be helpful, as when these lesions light up on PET, it means that they're active and can potentially be treated with steroids. The ACC recommends this kind of evaluation algorithm. Patients with extracardiac sarcoidosis and a reduced EF should get a cardiac MRI looking for sarcoidosis. If it's normal, then that's not to say it won't ever happen, and these people need to be followed. But if it is abnormal, then consider an FDG PET to help understand if the patient needs anti-inflammatories or an ICD. Case 4, this is another patient with sickle cell anemia who presented with lower extremity edema, abdominal fullness, and orthopnea. The patients had a history of multiple blood transfusions throughout their life. And you can see this patient has a cardiomyopathy with reduced LV systolic function, no hypertrophy, and don't have a measurement here, but just visually you can tell that the left ventricle is quite enlarged. So this patient has a cardiomyopathy, and beginning our evaluation for cardiomyopathy, always we get our usual routine laboratory values, Typically, everybody gets thyroid function, but what I want to keep in mind is that many bodies recommend that we also get serum ferritin and transferrin, essentially to screen for hemochromatosis or iron overload, as it is also a common cause of cardiomyopathy that I believe is probably underrecognized. Iron kinetics are complicated, but basically patients end up with more iron in their system that then deposits into the heart and forms an infiltrated cardiomyopathy. These patients typically develop a restrictive or dilated cardiomyopathy, and hypertrophy is uncommon. Hemochromatosis, hereditary hemochromatosis, that is, affects males more commonly, as it's an X-linked disease. These patients, as we said, usually have normal LV wall thickness and can develop conduction abnormalities and arrhythmias. Hemochromatosis is obviously a systemic disease. Patients can have hyperthyroidism, develop bronze diabetes, develop cirrhosis, and even develop sexual dysfunction. In patients that have idiopathic cardiomyopathy, we should certainly do our routine laboratory screening, but cardiac MRI is generally recommended when we don't have an obvious cause. And for the purpose of iron overload, cardiac MRI with T2 star mapping is very good at detecting iron overload in the heart. Iron overload is a unique circumstance when T2 star times are decreased by MRI. There are very few conditions that result in that. Here's a patient from a study in JACC a couple of years ago. A 45-year-old man with an idiopathic cardiomyopathy undergoing cardiac MRI, where things are normal. A 35-year-old lady with sickle cell anemia who has had iatrogenic iron overload from blood transfusion, and you can see that the heart as well as the liver is involved. And we typically see that in patients that have iatrogenic iron overload. And then the last one is a patient with hereditary hemochromatosis where the liver is involved, but not the heart. So CMR can help differentiate these conditions that way. Moving on to our fifth case. This is a 35-year-old lady who has worsening dyspnea on exertion. She also has a pruritic rash on her upper arms. Laboratory values show an elevated SED rate. This patient on echo has a laminar thrombus in the left ventricular apex. This is a very rare finding, but characteristic of a specific diagnosis, which is hypereosinophilic syndrome. This is a very unusual finding, and when you see it, it's quite alarming. So HES is defined as unexplained eosinophilia for at least 6 months and single and multiple organ dysfunction. The 3-year mortality is 75% if this is untreated. So if you find this on an echo, it's a harbinger of mortality, and obviously requires much more extensive evaluation. Contrast can obviously be helpful to identify thrombus. You can see that in this case, the echo contrast did not infiltrate the thrombus, and thus you end up with this little black spot. So in HES, there's apical thromboabliteration. In other words, the apex of both the LV and the RV can fill up with thrombus. The patients develop a restrictive diastolic cardiomyopathy. And there can also be subvalvular thrombosis and leaflet entrapment, which results in mitral and tricuspid regurgitation. So why does this happen? Essentially, these patients develop an eosinophilic myocarditis, which then prompts a thrombotic state along the endocardium, resulting in thrombus in the apexes of the LV and the RV. Eventually, that turns to fibrosis, and the patients develop a restrictive cardiomyopathy. When that happens, it's a very bad thing for the patient, but it's very important to keep this in mind, because if this is caught earlier in the disease, you can prevent cardiac dysfunction. Interestingly, at initial presentation, cardiac involvement is actually pretty low. As patients move forward with the disease, especially if they're untreated, cardiac dysfunction becomes more common. But usually the most common presentation is the rash, as in our patient who had an itchy rash. And this rash is usually presents as itchy erythematous nodules and plaques, and can resemble hives. Moving on to our next case. This is a 46-year-old lady who presented with left-sided weakness and was discovered to have a right MCA stroke. Interestingly, she has multiple clots in the past. She wasn't on anticoagulation at this time, and she also has a family history of TTP, which was a little unusual. And here's her short axis view of the aortic valve. And you can see one of the cusps has something on it. Looking at in the peristernal long axis, you can see one of the cusps has, well, it looks like a vegetation. So this patient, we sent blood cultures ×3, which were negative, and a procalcitonin, which was also happened to be checked, was also low. So we concluded that this patient had non-bacterial thrombotic endocarditis, which is the more formal name for the same condition as Liebman-Sachs endocarditis, Morantic endocarditis. These are all describing the same thing, but literature usually calls this non-bacterial thrombotic endocarditis at this point. Usually these patients are asymptomatic until embolization occurs, as was our patient. It's a rare condition, and post-mortem rate in autopsy is about 1%. So what happens is there's sterile platelet thrombi on the heart valves that deposit, and as that deposits, the clot kind of gets a little bigger. And what's interesting is that it usually affects undamaged valves. It's associated with advanced malignancy most commonly, 80% of the time. Lupus is next most common, about 10% of the time, and certainly a lot of other conditions as well. Our seventh case, this is a 56-year-old woman who presented with positional chest discomfort, shortness of breath, and palpitations. She also has a history of alopecia. Here's her EKG. You can see there's certainly tachycardia, sinus tachycardia that is, but there's ST elevation in lead 1, lead 2, AVL, AVF, and maybe in the lateral precordial leads as well. Certainly just doesn't follow a vascular distribution. So based on its EKG, it likely represents pericarditis. And here's the patient's peristernal long axis, which shows a pericardial effusion and obviously tachycardia in that setting. Here's the patient's subcostal image. You can see there's not tamponade as the right atrium is filling appropriately, but you can see that there's a pericardial effusion. And coupled with the patient's presentation, this certainly represents pericarditis. So the laboratory evaluation in this patient, she had a positive ANA, positive double-stranded DNA, and positive Smith, RMP, and SSA antibodies as well. So given her pericardial effusion, history of alopecia, ANA, and positive double-stranded DNA, she has systemic lupus erythematosus. So SLE can affect any part of the heart. Coronary artery disease is actually more common in patients with lupus, primarily because it's an autoimmune disease. The cardiac manifestations include pericarditis, as we just saw. Often, if you test the fluid, the pericardial effusion itself will be ANA positive, which is interesting. Myocarditis can happen, valvular disease, non-bacterial thrombotic endocarditis, as we just mentioned, as well as cardiac conduction defects. Interestingly, congenital heart block is also a feature. I know we're focusing on adult echocardiography, but just as a note, if a mom has lupus and they have anti-Ro and SSA antibodies, that's often associated with congenital heart block due to lupus. Moving on to our 8th case. Thanks for bearing with me on these cases. I have 10. This is a 44-year-old lady who presented with shortness of breath, tremors, palpitations, and lower extremity edema. And her labs were markedly abnormal. She had, this is the only patient I've ever seen to have out of the range of detection for these 3 studies, but she had a TSH that could not be detected, a free T4 that was beyond the level of detection, and a thyroid peroxidase antibody that was also beyond the level of detection. Here's the patient's EKG, and you can see that the patient is certainly tachycardic, but also has atrial fibrillation. Looking at the score for thyroid storm, this patient has atrial fibrillation, gives them 10 points. They were tachycardic, greater than 140, gives them 35 points, and they also, by the history, presented with heart failure. So using this score would be diagnostic of thyroid storm, obviously in this clinical setting. So this patient was treated for thyroid storm with methimazole, beta blockers, and anticoagulation. She spontaneously converted to sinus rhythm. After she converted to sinus rhythm, this was her echocardiogram. And you can see she has maybe mildly reduced LV systolic function, but she does have significant mitral regurgitation. She also has, probably worse, tricuspid regurgitation. And if we look at her non-invasive assessment of right ventricular systolic pressure, she has an estimated RVSP of 62. As you can see, the IVC is dilated. And using our equation, that gives us a mean PA pressure of 34, which is moderate pulmonary hypertension. So this patient presented with thyroid storm, rapid atrial fibrillation, and then was found to have pulmonary hypertension and significant mitral and tricuspid regurgitation. She eventually underwent thyroidectomy as she actually had a large goiter, and rather than radioactive iodine ablation. And she follows with me in clinic, and 1 year later, we repeated her echo, and the mitral regurgitation has essentially resolved. The TR, that's the pre-image. The TR also got better. And if we look at her, RVSP at this point, it's also normalized. So in Graves' disease, atrial fibrillation is common. About 10% of patients will have atrial fibrillation. It's more common in thyroid storm. Congestive heart failure is also common. 94% of these patients have coexisting atrial fibrillation. 50% will have systolic dysfunction, and that's thought to be due to tachycardia-mediated cardiomyopathy. And pulmonary hypertension is increasingly described. In our patient, she had significant mitral and tricuspid regurgitation, as well as pulmonary hypertension, that then essentially resolved after her Graves' disease was formally treated. And this has also been increasingly described. Here are two studies and a case report that describe that phenomenon. So this patient was actually referred to our structural heart clinic to evaluate for, do they need a MitraClip? But simply waiting after the patient's Graves' disease was formally treated resolved their mitral regurgitation and their pulmonary hypertension, which I thought was pretty interesting. Here's case 9, where this is a 70-year-old lady with a history of Graves' disease, status post remote radioactive iodine ablation, who was referred for an abnormal echocardiogram. Interestingly, she was recently admitted for complicated UTI with E. coli bacteremia. She got an echo because of the bacteremia, although it was gram-negative bacteremia. And here was her echo, and you can see that there's a small pericardial effusion. Now, this patient was asymptomatic, but they were essentially referred to assess for the cause of pericardial effusion. And as it turns out, the patient hadn't been as compliant with their synthroid. They'd had radioactive iodine ablation for Graves' disease many years ago, but a pericardial effusion is commonly found in patients with hyperthyroidism. Severe hyperthyroidism results in reduced cardiac output. And interestingly, hypertension is present in 20 to 40% of these patients. This is something interesting to me. When patients have hyperthyroidism, they particularly have a diastolic hypertension, so their diastolic numbers are usually more elevated. Knowing that fact makes me want to check thyroid function a little more commonly in clinic, but it just makes an interesting finding. And moving on to our 10th and last case, this is a 72-year-old man with a known metastatic neuroendocrine tumor being evaluated for worsening abdominal distension and lower extremity edema. This patient has certainly significant tricuspid regurgitation in the setting of carcinoid heart disease. So what is carcinoid heart disease? It's a condition where a patient has a neuroendocrine tumor, the carcinoid tumor, which releases vasoactive substances, which can then affect multiple areas of the body, but on echocardiography, most commonly affect the right-sided heart valves. Many different modalities can assess for cardiac dysfunction, but generally echo is first line. Carcinoid disease is a rare neuroendocrine tumor, as we just said, occurring in 5 out of 100,000 people. It releases vasoactive substances, particularly serotonin, but also many others. Carcinoid heart disease is a perineoplastic process, and of people that have carcinoid, 20% will have cardiac involvement. So how does this happen? Serotonin induces plaque formation on the valve cusp and subvalvular apparatus. Essentially, they're myofibroblasts, smooth muscle cells, and extracellular matrix that deposit on the heart valves. The valve cusps thicken, stiffen, and retract, leading to both regurgitation and stenosis. On the right here, you can see a patient's pulmonic valve after a valve replacement. Here's the specimen after the valve is replaced. You can see how thick the leaflets are compared to a normal pulmonic valve. So tricuspid disease, typically the patients have a dilated tricuspid annulus, which then leads to tricuspid regurgitation, but the leaflets are diffusely thickened and retracted. These patients can often develop torrential TR due to essentially coaptation gap. Same thing happens with the pulmonic valve. The pulmonic valve becomes thickened and retracted, reduced leaflet mobility, and these patients develop pulmonic insufficiency as well as stenosis. So carcinoid heart disease, treatment of the tumor usually does not lead to regression of valvular disease, and that's important to keep in mind. If these patients develop severe valvular dysfunction, surgical treatment is often necessary. And it's also important to keep in mind that the left-sided heart valves can be involved, though this is unusual. But that occurs when there is a shunt, say a PFO with a good amount of communication, or if the patient has bronchial lesions, which would essentially be after the capillary bed in the lungs. So in review, there are specific patterns of cardiac dysfunction which can provide clues to underlying systemic diseases. Echocardiography can serve as a marker of disease and prognosis. And I think of echo as often a clue to look further. So with that, I'll say thank you. And if you have any questions, I'd be happy to answer.
Thank you, Dr. Corrigan, for this extensive review of echocardiography in systemic disease. I do not see any questions in the chat box at this time. So we will proceed to the next speaker.
All right, thank you.
Thank you. We're waiting for Dr. Ashwa to come on. Our next speaker is Dr. Sivaram. Dr. Ashwa to join us to introduce him in a little bit.
Thank you very much, Frank, for that excellent review. Can you guys hear me okay?
Yes, Dr. Ashwa.
I'm going to request the planning committee to please join me if you're able to. Kofi, Roy, and Jay. So we are going to be starting the last talk of our lecture series, 32 lectures in whole. It's definitely been a lot of work. I want to take a minute to thank all the efforts of the planning committee, the FIT co-chairs, Kofi and Jay and Roy, our social media representative, put in a lot of effort to make this a very successful series. And thank you to all the speakers. This lecture series would not have been possible without all your contributions and your efforts. So thank you all for making this possible. Jay and Kofi, did you want to say anything?
Sure, Dr. Ashwath. Thank you very much for this opportunity. I think it's been a great lecture series. I really want to thank all the speakers. They've gone above and beyond for fellow education. And I've personally learned a lot. And I'm sure all the fellows who've been listening, they've all benefited a whole lot from this lecture series. And all the fellows who are going to review it at a later time, they're all going to benefit, especially the ones who are going to give echo boards this year. So I thank all the speakers and thank you, Dr. Ashwath, for this opportunity.
Yeah, and I think Jay echoed my feelings as well. So thank you, Dr. Ashwath, for this opportunity. And we appreciate all the speakers. It's been an amazing 4-week marathon of lecture series. And hopefully this will help us pass our boards.
Yeah.
We appreciate all the speakers.
Again, I think this, it's definitely been 4 weekends and 32 lectures. It's definitely a lot of work. Kofi and Jay, as like most of the other fellows, have had their calls, have they had their commitments and everything, and still, kept up with these lectures. They kept me on track when I was on call and rounding, informing me when I was ready to be on screen again. So again, would not have been possible without their efforts or without the contribution from all the speakers. So thank you to everyone again. I'll move on to introducing our speaker, our next speaker, Dr. Sivaram. Dr. Sivaram actually spoke for us yesterday, and turns out that yesterday was his birthday, and I didn't know about it. So a belated happy birthday to Dr. Sivaram, and thank you very much for taking your time out of your special day and speaking to us on that day. Dr. Sivaram holds the David Royce Boyd Professor title at the University of Oklahoma and serves as the Vice Chair of the Cardiovascular Section, Associate Dean for Continuing Professional Development for OU College of Medicine, and Vice Chair for Undergraduate Medical Education in the Department of Medicine. He joined OU in 1993 after being on the faculty at Texas Tech University Amarillo campus for 9 years. He served as the Director of Cardiology Fellowship Training Program at OU for 23 years from 1995 to 2018. Purvi just mentioned that she was one of his fellows, and I think it's very gratifying to see all the successful fellows you have mentored along the way, Dr. Sivaram. He's the current director of the Echo Lab at OU. He's actively involved in student, resident, and fellow education and has mentored many trainees over the years. He has served ACC both nationally and at the state level and was instrumental in creating the CV training section, the home of the cardiovascular fellowship program directors within the ACC. In addition to receiving multiple teaching awards at OU, he has received the Gifted Educator Award from ACC in 2015 and the Lennec Master Clinician Award from the AHA in 2017. And he maintains an active clinical practice. Over to you, Dr. Sivaram.
Well, thank you, Dr. Ashwath. Hopefully you can all hear me.
Yes.
And my screen is up and running. So I want to congratulate the whole ACC Iowa team, including the fellows, for the wonderful job that you have done in getting this together. So mine is the bookend of this very large program. Hopefully you are not too tired to go through another 60 minutes of instruction. I will be talking to you about evaluation of pericardial disease. It's not advancing. Like, I have trouble in advancing this. Okay, it went through. I do not have any disclosures relevant to this presentation. What we're going to do over the next 60 minutes or so will be to review the presentation of common pericardial diseases, with our focus being on 3 or 4 entities: pericardial effusion, tamponade, and constrictive pericarditis, which are the 2 or 3 top items that you must be ready when you take the echo boards. And we will talk about the important echo features in common pericardial diseases. And I added in this list 2 other conditions that are not very common, but happen to be very popular topics for the examiners: pericardial cyst and congenital absence of pericardium. Again, I will probably not be focusing so much on getting you ready for the exam as some of the other speakers, but I'm certainly interested in getting you ready for what comes after the training. So here is a clip, and question number 1. I would like you to comment whether this clip shows a small or trivial pericardial effusion, moderate loculated pericardial effusion, large loculated pericardial effusion, or no pericardial effusion. I am unable to see the chat box, so hopefully there will be at least some answers.
Yeah, most are saying option 4.
Okay. All right, let's go to the next one. What does this M-mode parasternal long axis view show? Obviously, I'm not giving you a list to choose from because this is the last session. So the difficulty of questions are going to go up. I'm almost asking you to fly the trapeze without a safety net. Let's see whether you can do that. Do you have some answers? Okay, if you do, then it's okay. Then we can move to the next one. All right, so this is an M-mode echo from a patient with the constrictive pericarditis. What are the findings that this static picture shows? List all of them as you may see fit. Okay, so let's actually move on to the main presentation. I believe that pericardial diseases constitute one of the very important core skill that an practicing echocardiologists need to know. And it also happens to be a very interesting, somewhat complicated topic where to save the patient from having a bad outcome, what we need to know is so little compared to all the nuances that make the topic highly interesting. So let's start with pericardial anatomy. So these are slides taken from a 2013 Journal of American Society of Echo publication. It is an excellent topic, excellent resource for you to look at, and it deals with the multimodality imaging in pericardial disease. So let's start with these pictures. I probably am not overstating if I say that this slide is the most important slide that I'm going to show you today. So the first one is a picture of the heart harvested from the chest before the pericardium is taken out. So this is the diaphragmatic surface of the heart, and you can see significant amount of fat that is between the pleura and the pericardium and the diaphragm. And these 2 lines indicate the pleural reflections. This is the left pleura, this is the right pleura, and they come forward and get attached to the sternum. And you can see that there is a lot of the left pleural surface that overlies the right ventricle. By the way, let me double check. You can see my pointer, correct?
Yes.
Okay, thank you. So, you know, this is a misconception that I had for a very long period of time, which is that left-sided pleural effusion, which will be between the visceral and parietal layers of the pleura, will never be seen over the right ventricle. That's absolutely debunked by this picture. So sometimes left pleural effusion can come anterior to the RV. It's not very common, but it does occur. So most of you probably have experienced this conflict where an anterior fluid space you think cannot ever be pleural effusion, but it does, okay? So the next picture, picture B, is equally important. Now what has been done is to take out the pericardium from the anterior aspect. So this shows very clearly that the pericardial space extends beyond the atria and the ventricles to cover a few centimeters of the two great vessels. Here is the RV outflow tract and the pulmonary artery. Here is the aorta. So the aortic root and the pulmonary root are within the pericardial sac, a very important point that explains why we get in aortic valve endocarditis and root abscess. One of the clues is pericardial effusion. We also know that very proximal aortic dissection can rupture into the pericardial sac. It is because the root is within the pericardial sac. And also these two small structures seen anteriorly are the atrial appendages. So left atrial appendage, right atrial appendage, they do have a pericardial space outside them. So the major pericardial sac has several recesses or extension. One is retroaortic, that's called the transverse sinus. You see that quite a bit in TEEs. And there is another extension of the pericardial space, which is outside the left atrial appendage, which is the oblique sinus. So this anatomic picture very clearly helps us understand some of the things that we see in TEEs and sometimes can be mistaken for pathology where nothing exists. Now the next set of pictures show the significant amount of fat that is normally present over the anterior right ventricular wall. Look that there is not much fat outside the left ventricle, but anteriorly there is quite a bit. In obese patients, there may be a lot more. And also the right AV groove has normally a fair bit of fat, which may be misconstrued as a mass in the right atrium. And I've seen patients getting referred for TEs and cardiac MRs and so on unnecessarily. So the last picture is a schematic diagram that shows the reflection of the pericardium to cover the proximal part of the aortic and pulmonary trunks, okay? Now I have a question for the audience, and I also have the answer here. It is very common to have a little bit of space outside the aortic root, extending all the way up near the SVC. This is the area that is indicated by the asterisk is the inferior aortic recess. This is a very important anatomic detail, which should be kept in mind, not to unnecessarily call abscess or dissection and other wrong diagnoses in patients. The normal amount of pericardial fluid is less than 50 mils. So this is a table that we will go through very quickly. Why do we have pericardium? By the way, we don't have anything in our body that is unnecessary. Maybe appendix may be an exception to that. So a very important function of pericardium is its effect on chambers. It limits short-term cardiac distension. If that were not the case, if we are exercising or our cardiac output goes up, the ventricles are going to dilate. So pericardium restrains the ventricular chambers from dilating acutely. It also provides the necessary nudging, as if it were, for the two cardiac chambers to couple together and interact together, and it maintains LV geometry. Then it has a lubricating function. It functions as a mechanical barrier to infection, which prevents mediastinal or lung infections from getting into the pericardial sac. And at the bottom of this table are listed some less relevant to daily clinical care functions of the pericardium. Okay, there is very little use of echo in acute pericarditis. One should not order acute pericarditis echoes, but this is there in this article, so we'll go through this very quickly. Here is a parasternal long axis view. A small amount of pericardial fluid, the echolucent space, is seen both posteriorly as well as anteriorly. One of the very important details about pericardial reflection is that it stops outside. The two layers of pericardium fuse outside the left atrium. So left atrium is the only cardiac chamber that does not have a pericardial space outside it. And here you can see the very bright signal from the parietal pericardium that clearly is out, outside or inside, depending on your perspective, the descending thoracic aorta. So this is a very helpful clue, like most of you used for the first quiz, that if you see a fluid space behind the cardiac chambers posteriorly, and if it includes the aorta, descending thoracic aorta, that cannot be, repeat, that cannot be a pericardial effusion. That's always indicative of a pleural effusion. So in acute pericarditis, you'll see a small pericardial effusion. You generally do not see any wall motion abnormalities. Some patients with acute pericarditis with minimal amount of fluid will have a completely normal echo unless they have some underlying cardiac disease. The pericardial signal brightness may be increased, even though in terms of practical clinical application, this is so subject to the gain setting use. Of course, the paper that I took this table from is a multimodality imaging statement. So we have CT and CMR. I will not read through that. You can look at it in case you're interested. All right. Often we get confused with what I call here the big pretenders. We already talked about how the left pleural effusion is often a challenge in patients with a fluid sac, fluid space that you see in a parasternal long axis view. We talked about that. Here is the pericardial reflection that stops without involving the descending thoracic aorta. The pleural effusion completely is in contact with the descending thoracic aorta because of the anatomic location. The other common dilemma that we get into in clinical care is whether something anterior to the RV is an epicardial fat, or is it blood in a pericardial sac, and so on and so forth. Now, the article that I made a reference to states that the epicardial fat will be very closely applied to the RV free wall and will move in concert with the RV free wall during systole and diastole, as opposed to an exudate on the pericardium anteriorly. It will have little less movement that is always in conjunction with the RV free wall. Having said that, all of us know there are times when we have to really struggle to decide, are we looking at epicardial fat or fluid? The example that's shown on the left side has both a little bit of fluid as a little bit of fat, which makes the challenge less difficult, okay? So I'm going to show you an example. These are real life examples. The patient is someone who is hypotensive a few days after mitral and aortic valve replacement. The echoes were done in the same admission as the cardiac surgery. So here is a parasternal long axis view. It is pretty obvious that there is a posterior fluid space. You don't see the aorta too well. There is no or very little anterior fluid space, the RV is dilated, and you clearly see that the layers of pericardium, the parietal and visceral, where my pointer is, hopefully you can still see it, they move together, suggesting that there is a little bit of adhesion, which is not surprising considering the fact that this is a post-cardiac surgery patient. When you go to the parasternal short axis view, the fact that there is a circumferential large pericardial effusion is pretty obvious. RV is dilated, RV is dysfunctioning, and anteriorly, the pericardium over the RV free wall, the two layers are kind of adherent. This is an acute process because of thoracotomy. And you can also see that this white line, which is the parietal pericardium, and the second white line, which is the visceral pericardium, they kind of pull on each other because of the adhesion. All of that is pretty obvious. My question to you, and if you have an answer, you can put it in the chat box. What else are we seeing in this patient's clips that should concern us? Now, I cannot see the chat box, so I will assume that somebody is looking at it. If you look at the way the septum is, pardon me?
I am looking at it, and septal flattening, LV collapse. That's what people are putting in the chat box.
Yeah, I think I'm really glad that you looked at the very abnormal fashion in which the septum is moving. This is very characteristic of what is referred to as ventricular interdependence. If you look carefully, the distance between the RV free wall and the posterior LV wall remains fairly constant because this fluid's pericardial effusion is under pressure, which is setting a lower limit and a fixed limit for the space that the two ventricles can occupy. If during inspiration, the RV is going to get bigger, the LV has to become smaller, which causes the septum to move chaotically. Now, the real challenge in actual practice, I don't think what I'm going to say is really an exam helpful point, is that most of our clips are acquired with 3 or 4 beats. So it is very easy, depending on luck of the draw, that the clip did not include enough number of beats for you to decide on any abnormal motion of the septum related to respiration. So I always tell my sonographers that you get to see a lot more than we, the physician, get to see at the time of reading. So this requires an astute interaction between the scanner and the image in real time. So this is one example of ventricular interdependence that you may be able to see on the echo. So this is the same patient's apical 4-chamber view. You can see the prosthetic valve, that there is a mitral prosthetic valve, there is a large pericardial effusion, and see the way it ends at the mitral left ventricular AV groove level, because there is truly no pericardial space outside the left atrium. And you probably know, if you attended my session yesterday, that I am a huge fan of off-axis views. So this is really an apical 4-chamber view, the thing that is seen, the clip that is seen on the left side, with a slight downward angulation. If you look at the clip at the end, you can see the 4-chamber view starting to come up like there. So this kind of views help you decide or appreciate how large this fluid space is beyond the apex, at least, left to right dimension. And you can see a lot of moving, almost like contrasty areas, which indicate that this is either blood or a fluid that is very rich in protein, and definitely an exudative pericardial effusion. Same patient, apical 3-chamber view, large effusion, the exudate. And of course, this view was done with the aim of showing the effusion. So that's why you're not seeing the rest of the pictures that well. This is an M mode through the parasternal long axis view, somewhat oblique, but that doesn't matter, but it shows the very chaotic movement of the septum and the reciprocal relationship between RV size and LV size. When RV is bigger, LV is smaller. When LV is bigger, RV definitely smaller. So the septum has to move back and forth. And what is very characteristic in ventricular interdependence is this abrupt change in the septal orientation, which clearly means that this is not a slow respiration related change in RV and LV size. So this M mode is an example of ventricular interdependence. Okay, now one of the diagnoses that sends the cardiac team, be it the clinical team, interventional team, or echo team, running to take care of the patient is cardiac tamponade. This is a very important topic. And I would say, having been a clinical cardiologist for several years and being a clinical teacher for same number of years, there are several aspects of tamponade that are very simple, and there are some aspects of tamponade that are much more nuanced and a lot of times a little more difficult to understand. And I would say that in 2021, the cardiologists really need to have a very extensive knowledge about tamponade, because a lot of our colleagues in the ER, critical care, anesthesia, and so on are really practicing echocardiography now. And if I were in the midst of them, I would definitely want to feel like I have more knowledge that I can bring to the bedside to help the patient to be taken care of better. So this is an important topic. That's what I'm saying, okay? So basically, on the right side of the screen is described what tamponade is. It's a state of low output or hypotension that is due to high intrapericardial pressure that compresses the ventricles, both right and left, right more than left, because right ventricle is thinner walled and allows more compression. And whether it is due to compression of RV or direct compression of LV, the left ventricular filling is reduced, because if the RV is compressed significantly, since RV provides preload to the LV, the LV filling is going to be reduced. So the net result is hypotension. So this is a low output state that is due to external compression of the ventricle and not due to pump failure. As such, the hypotension of tamponade will not be improved by giving inotropic agents. So there are, this particular schematic diagram is famous, and it's famous for a very good reason, because it shows the effect of pericardial volume on the x-axis to pericardial pressure. As pericardial fluid accumulates, when it accumulates slowly, the pericardium can distend, or because the pericardium is compliant, it can take in fair amount of fluid till you reach a point of maximal distensibility of the pericardium, at which point any further accumulation causes the pericardial pressure to go abruptly straight up. So this is not a straight line, it's a curvilinear relationship. And where the relative parallel part of the curve turns into shooting upwards is where the pericardial stretch or compliance has been completely spent, okay? Now, the blue line indicates the behavior of chronic slow accumulating pericardial effusion. If the pericardial effusion accumulates rapidly, there is really no time for pericardium to distend and accommodate the fluid without unusually critically elevated pressure. So the curve is shifted to the left in rapid effusion, and the pericardial restraint is overcome very early. So this is a very important point, because what basically it says is that the volume of pericardial effusion is important, but a small effusion can produce tamponade if it accumulates rapidly. Because my experience in having conversation about echo findings with the non-cardiology teams is that they always seem focused on the size of the effusion. Yes, it is important, but the rate at which the pericardial effusion accumulates is just as important. So in the smaller box below on the right side are listed What causes intrapericardial pressure elevation in pericardial effusion? Rate-time accumulation, volume, or the size. And number 3 is pericardial compliance. I don't think we know a lot about pericardial compliance, and I have no idea how to measure it. I don't have no idea how we can change pericardial compliance. So items 1 and 2 are more important than pericardial compliance. Okay, very quickly, I will go through this list. Clinical findings in tamponade. Usually there is a predisposing condition, post-cardiac surgery, ablation lab, hypotension, interventional procedure-related hypotension, chronic kidney failure, dialysis, and so on, cancer. And the patient usually presents with tachypnea, tachycardia, and hypotension. There are a couple of exceptions for tachycardia, and I really don't know why the exceptions occur. Uremic pericardial effusion and tamponade and usually doesn't produce tachycardia. Of course, mixed edema is a little more understandable because in hypothyroidism, the heart rate is slow. Friction rub, which is one of the major findings in acute pericarditis, is frequently absent, or because the 2 layers of pericardium no longer rub against each other in presence of an effusion. Central venous pressure or jugular venous pressure is elevated in all patients with tamponade. Now, there is no exception to tamponade without CVP elevation or jugular venous pressure elevation. And these days with the point of care ultrasound, that's also the IVC plethora. The classic jugular venous pulsation, pulse wave abnormality in tamponade is absence of a Y descent. Pulsus paradoxus, which is an inspiratory systolic fall in arterial pressure more than 10 millimeters of mercury during normal breathing, normal. You should not ask the patient to breathe heavily or deep when you measure the pulsus paradoxus. And we also know that pulsus paradoxus is not specific for pericardial tamponade. It can occur in massive pulmonary embolism, ventilated patients, and COPD. Now, this slide lists all the important findings on echo in pericardial tamponade. Now, I will just read it, and we're going to kind of editorialize on most of these points in the subsequent part of the talk. Right ventricular free wall early diastolic collapse is a very important echo sign. We must look for it, and we must actually report it if it is absent or present. If the diagnosis that caused the echo to be done is tamponade or suspected tamponade, right atrial late systolic collapse or inversion. Most of these terminologies used here are very, very important. Right atrial, late systolic collapse, late systolic collapse. So essentially, the collapse doesn't mean a small ventricle or small atrium. This is a very common misunderstanding or misconception. Basically, what we're looking at the wall of the right ventricle and see that it gets pushed inwards, or it gets inverted or dimpled during certain time in cardiac cycle. We will go over that as we go to the next slides. Respiratory variation in mitral and tricuspid Doppler. The most frequent misconception and mistake about this is these variation apply to the E velocity, early filling velocity for both mitral and tricuspid valve, E velocity, not the late velocity. Sometimes the A velocity or late filling velocity is the taller one, and the sonographer or the cardiologist or whoever does the reading looks at the more prominent evident one. No, these variations apply to the early filling velocity E. Ventricular interdependence, which can be on echo seen either on M mode, or you could see that in tricuspid or mitral regurgitation Doppler signals. IVC dilatation. It is just an extension of high venous pressure that we talked about earlier. Absent inspiratory collapse, which is again a feature of high right-sided filling pressure. And a very important, interesting, seemingly not logical finding in the hepatic vein. You get the diastolic flow reversing during expiration. We'll try to explain why that is as we move along. Now, of all the things listed here, in terms of something that is going to challenge an exam taker in the echo boards will be the last one, because we generally associate everything on the right side of the heart with inspiration, but this finding refers to expiration, even though it's a right-sided venous phenomenon, okay? Now, I don't think this is important from an exam point of view, but in terms of understanding the pathophysiology or pathogenesis of cardiac tamponade, this particular slide is absolutely essential. And one of the benefits of understanding this is, remember, when we learn something, we have to understand it the first time, which is challenging as it is. Then you have to be able to recall that without an aid, like checking your Dr. Google, for example. So this is from Dr. J.O.'s textbook. It shows the lung, the intrathoracic pressures. Here is the left atrium communicating with the intrathoracic structures through the pulmonary veins. And here is the LV with its pericardial space. Normally, the intrapericardial pressure is equal to the cavitary pressure, and the intrathoracic pressure, they fall in tandem during inspiration and expiration. If you look at this line, this is the intrathoracic pressure. The bottom line is the intrapericardial pressure. They move in tandem during respiration, which causes very little variation in the gradient between the pulmonary veins within the lung fields and the left atrium. So that's why the mitral inflow Doppler and tricuspid inflow Doppler, based on this, the same analogy, they don't change much during respiration. In cardiac tamponade, the pericardial space is not available anymore for business because it is filled with fluid. And you could also use the same logic in constriction because the two layers of pericardium are now stuck to each other. There is no pericardial space, which results in a dissociation of the intrathoracic pressure shown in this upper line and the pressure in the pericardial sac, which doesn't change as much. This results in a completely different pressure phenomena between the pulmonary veins, which is actually driven more by the pressure changes in the thorax, and LV and left atrium, which are absolutely driven by the intrapericardial pressure. So that's why you get this very marked significant changes in the velocity with respiration. This is a slide that compares CT, MR with echocardiography, but my job is to just go over echo. So the main strengths are very obvious, but it's worth making a plug for echo. It is the first line of imaging tests. It is readily available, low cost, it's safe. It can be performed at the bedside in urgent situation, tamponade, for example. It is portable. It has got high frame rate. It can be combined with a respirometer in most patients. And CT and CMR, you cannot. Now, the main weakness is limited windows, technically limited in obesity, COPD. And the third bullet, I completely agree. This is very operator dependent. In fact, it seems to me that the CT and CMR techniques are much less operator dependent than echo. So my challenge to you would be, if you want to be actually a very good skilled echocardiographer, you need to have a lot of experience, and there will be a growth curve even after you graduate when your skills are still evolving, okay? So this is again borrowed from the 2013 Jace article. So this is a patient with a very large left pleural effusion. It's outside the descending thoracic aorta. Anteriorly, there is a fluid space, which is pericardial effusion. And if you look at the RV free wall, you can see that it is suddenly buckling posteriorly in a very limited time. Now, a lot of times in real time, in moving picture clips, it may be much more challenging. the most common mistake that I've seen newcomers to the field make is that they know that the patient has a pericardial effusion. They clinically are worried that the patient may have tamponade, so they misconstrue the RV wall's inward movement during systole as RV collapse. So that's where M-mode, even in 2021, with the wealth of technology that we have, really is very, very helpful and must be done. So this shows an M-mode, which is done. If you're a purist, you would say, okay, well, this is such a bad angle, but it doesn't really matter because we are not trying to measure cavity size. We are trying to show the behavior of a suspected area that looks like maybe showing RV diastolic collapse early in diastole, its behavior in a frozen frame with a very high frame rate. If you look over here, you can see. Now, if you look at the EKGs are very small amplitude. This is one of my really pet peeves. The EKG signal has to be adequate height for us to make sense of what's systole and what's diastole. You see here, the free wall of the RV comes in during diastole. And if you're wondering, are you sure? Looks like that's the QRS complex, but what if I'm a skeptic and I don't believe it? Here is the something I don't think it is mentioned in this diagram's legend, but here is the aortic valve. We know that aortic valve opens during systole, and this is where the systole ended. So that should be diastole, correct? Look where the RV free wall is coming in vis-a-vis where the aortic ejection stopped. So this is clearly a focal, short-lived diastolic collapse of the RV free wall. In case, why did it kind of correct itself? All the collapses, RA collapse and RV collapse, have to do with the fact that at that moment, the pressure within the pericardial sac exceeded the intracavitary pressure. That's the whole basis for collapse of these chambers in tamponade. Now we know that the RV at the end of systole has just driven all its stroke volume out. It is really very small and it is relaxing, particularly before the rapid filling has started. That's the time when the RV is most vulnerable to be overcome by the intrapericardial pressure. So that's why the backward buckling or inversion or collapse is most prominent in our early diastole. As the RV fills, as diastole proceeds, there is enough intracavitary pressure to overcome the push from outside. Now, ventricular interdependence is a very simple concept. We kind of mentioned that in passing. It's a very important concept, though. Generally, the RV and LV are working okay because they share the septum and there is order. No one is actually pulling the septum one way or the other. During inspiration, in many conditions, including constriction and tamponade, since the ventricles don't have unlimited space to expand, when the RV fills, the septum is pushed towards the LV, making the LV cavity smaller, and LV volume is smaller, so LV filling is reduced, and some of the Doppler parameters actually drop. This is also the reason why you get a drop in systolic pressure in tamponade when you check the BP during inspiration. The pulsus paradoxus explanation. So during expiration, the opposite happens. So this sequential change in the ratio of RV to LV during inspiration and expiration is a very simple way to explain ventricular interdependence. Now, the IVC should always be checked in patients with tamponade, and we always do that. The IVC is dilated, just like jugular venous pressure is elevated, and it doesn't collapse well. And I'm sure all of you are very familiar with the standards for what constitutes IVC plethora or failure of IVC to collapse. Now, this is one part of the echo imaging that many of our colleagues, including hospitalists and ER physicians, will be very used to because they use a lot of point of care ultrasound. Now, this is again a composite diagram that shows the RV free wall collapse that occurs during early relaxation. And here is a right atrial collapse or right atrial indentation. Let's actually talk about that. And we are going to use the same analogy or basic logic that we use to explain RV free wall collapse. Now, the chambers get compressed or pushed inside when the pericardial pressure exceeds the chamber's cavitary pressure. So right atrium has low pressure anyway, and during diastole, the right atrium is sending all its filling into the RV. So at the end of diastole, the right atrial pressure is very low, or lowest if you kind of continuously monitor it during cardiac cycle. And that's during early systole, and late diastole kind of overlap slightly. So early systole is the time when the right atrial free wall collapses. Late systole, I'm sorry, if I said early systole, I beg your pardon. Late systole, early diastole, late systole, early diastole. Again, going back to this interaction between intrapericardial pressure and intracavitary pressure, that explains why we do not see LV collapse in most patients with cardiac tamponade, because the LV is fairly well muscled. The amount of intrapericardial pressure that will be needed to compress LV will be so high that by the time patient reaches that point, they would have already collapsed. And why does the left atrium not show collapse? Because it has no pericardial space outside, okay? Now, the behavior of mitral and tricuspid Dopplers in tamponade is very important, and it is clinically important, and I guess it goes without saying it is an important finding in an important point to check in exam. Now, there are really good ways of doing it, and there are kind of suboptimal ways of doing it. So this is from that publication. It shows the transmitral pulse Doppler. It is sampled just like you would sample any pulse Doppler for mitral valve at where the two leaflets almost co-opt at the inflow. You must have a good respiratory signal. It's not always available. Sometimes these patients are very sick that they move, or the contact with the chest is not, the marker is not as good. So you don't always get to deliver this. There is always a reality that comes in the way, okay? So first of all, let me tell you something which may be completely unnecessary, but I think it is sometimes a cause of confusion. The respiratory markers go like this. These are sensors on the front of the chest. So during inspiration, they will always go forward or to the front. And so that'll be expiration, inspiration. So in the exam or in real life, they don't come, always labeled like this. So then the next thing is, this is early filling or the E velocity, late filling, A velocity. As I said earlier, what really we are worried about, or we are interested in, is the behavior of E velocities during respiratory cycle, not beat to beat, but respiratory cycle. So the first beat after inspiration in tamponade, the E velocity after inspiration, and the first after expiration are what we are interested in. And in tamponade, these velocities would be very different from each other. And it's fairly easy to appreciate this visually, but we need a measurement. So the difference more than 30% between the first beat after expiration and the first beat after inspiration is what constitutes significant respiratory variation. Now, since the left ventricular filling changes depending on which way the septum is oriented related to the respiratory cycle, you'll also get, if you do the aortic Doppler, a varying velocity, which is a surrogate for stroke volume. And this is very clearly the echo Doppler counterpart for pulsus paradoxus. Now, one of the most interesting, in my opinion, and also most important and somewhat tricky or doesn't make sense type of finding in Doppler in cardiac tamponade is the behavior of hepatic vein Doppler tamponade. So I urge you to read this paper, and also this is going to require a little bit of reflection as to completely grasp it. So this is the sampling is done from the hepatic vein. Here is the IVC, here is the hepatic vein. And hepatic vein Dopplers are very similar to pulmonary vein Dopplers. They show forward flow during systole and diastole, and maybe a little bit of reversal during atrial contraction. So the hepatic vein and IVC flow significant inspiratory increase. So that's normal. And what happens in tamponade is that the diastolic velocities are very low. And during expiration, the diastolic velocity or signals reverse. Now, an easy way to kind of wrap your head around this is that the diastolic velocities occur, as the name indicates, during diastole. So that's the time when blood flows from the great veins and hepatic vein into the right atrium and forward into the RV or LV, depending on which vein you're talking about. Tamponade is a condition that limits ventricular filling. So the diastolic velocities are low because diastole is impaired in tamponade, so that's why these velocities are low. What happens during expiration? Which ventricle gets to take the bigger cut of the volume that is available? Left ventricle. So the septum is actually now moving towards right ventricle, which makes this problem of diastolic filling much worse, causing the diastolic flow signal to reverse, okay? So this is, again, another example of M mode that shows ventricular interdependence. So this is the RV free wall, here is the LV posterior wall. The space between these two is limited or fixed in pericardial disease. So when the RV becomes bigger during inspiration, the LV has to become smaller and vice versa. And there is a nice respiration marker that helps you follow through this particular pattern. So I'm going to show you a slide. I think it is the next slide that compares the physiology between constrictive pericarditis and cardiac tamponade. There are lots of similarities because both constrictive pericarditis and tamponade are problems that impede ventricular filling, but there are some clear differences between the two. So this is the perfect combination slide of everything that you see in constrictive pericarditis. The mitral inflow signal shows a pattern, usually what we refer to as a restrictive pattern, which goes with a high left atrial pressure. Same is the case with the tricuspid valve. You know, there is a high right atrial pressure. The expiratory diastolic flow reversal in hepatic vein, this should have been hepatic vein, is the same. But what's really different in both constriction and in helping differentiating between constriction and restrictive cardiomyopathy is the SVC dynamics. The SVC dynamics are completely untouched in constrictive pericarditis. This is not something that most labs find it easy to do. Where to sample for SVC requires a lot of technical challenge. And lastly, in constriction, the annular velocities, which is an acronym for a term for tissue Doppler velocities from the mitral annulus and the lateral and medial annulus are not reduced, but they are actually exaggerated. This finding really helps to distinguish between constrictive pericarditis and restrictive cardiomyopathy. Restrictive cardiomyopathy, as the name indicates, is a muscle disease. There, the tissue Doppler velocities will be lower than expected. In constriction, the annular velocities are not only intact, they are usually exaggerated because the early filling in constriction is very efficient, because that's the only time the ventricle can fill in constrictive pericarditis before the thick pericardium says, no, you're not allowed to fill anymore. So the annular velocities are actually exaggerated. And most of you know this, this annular reversus terminology. If you look at the annular velocity from the septum versus the lateral annulus in constriction, the septal annular velocities are usually higher than the lateral. And this has to do with the fact that the lateral wall is somewhat restrained by the thick pericardium while the septum is not, okay? I will kind of skip that. We have covered most of this. This is an important slide, again, taken from the same article that I mentioned. This compares cardiac tamponade and constrictive pericarditis pathophysiology. If you kind of look through that, they're all the same except 3. In cardiac tamponade, the Y descent is diminished or absent. In constrictive pericarditis, it is actually exaggerated. I really think this is a very useful clue because it is binary. They go in different ways. It's not shades of one, which is always much more difficult. So clinically, if you think patient has pericardial tamponade and you are able to see a very rapid Y descent in the jugular venous pressure, your diagnosis of tamponade is actually wrong. Then the other difference between the two is pulsus paradoxus. It is common in tamponade. It's not seen in constrictive pericarditis. Kussmaul sign, which is paradoxical inspiratory rise in venous pressure, seen in not seen in tamponade and seen in constriction. Okay. We're going to go over 2 conditions which are both very rare, but kind of important from the exam point of view because due to reasons that I'm not entirely sure, question writers just love these 2 entities. One of them is pericardial cyst. Pericardial cyst produces an echolucent space adjacent to the ventricles. More common, this is a CT or MR image. So this is RV. It is much more common outside the RV compared to the LV. As you can see, the most common confusion is this a loculated pericardial effusion? Sometimes the differentiation can be difficult, but usually the clinical clues will be completely asymptomatic patient who gets an imaging for trivial reasons, and you see this little echolucent area. This could also be, if it is outside LV, may be confused with a pseudoaneurysm of the LV. We talked about that yesterday. Now, the other differential diagnosis is pericardial diverticulum. If you look at the first line of this table, the difference between the two is the pericardial cyst will be outside the epicardium, while pericardial diverticulum will be actually in communication with the pericardial cavity itself. It's obvious that these are sometimes very difficult to distinguish even for an experienced operator. You must know something about congenital absence of pericardium going into your exam because not because it's very common, but it's kind of an interesting thing. As the name indicates, this is absence of pericardium congenitally. Most of the time it is partial absence, and the absence is along the lateral wall of the left ventricle. So basically causes the ventricle to be, the right ventricle to look a little more prominent than usual. The heart function is somewhat exaggerated, almost like an exaggerated mobility, because there is no longer pericardial restraint. Usually these patients do not have any other significant findings. Okay, coming back to our questions. First question, most people got this answer correct, right? Kofi or Jay?
Yes, most people got this correct.
Yeah, so the RV is actually big. I'll play it one more time. RV function is reduced. maybe a little bit of septal hypokinesis, possibly due to RV overload. Posterior wall, you can clearly see the line of the visceral pericardium and the parietal pericardium. There is probably a small amount of fluid. This is a large fluid space. It is clearly outside the epicardium, sorry, the parietal pericardium, outside the descending thoracic aorta. So this is a large pericardial pleural effusion, pleural effusion. And if you look very carefully, you can see that the two layers of pericardium are moving with each other. So they're kind of tethered. They should not really move against each other together. They should kind of slide over each other. A small point, not really important from an exam point of view, but just for your practice, okay? So what does this M mode show? Anyone? I'm not able to see the...
Waiting for a response.
Yeah, ventricular interdependence, okay? So this is a patient with constrictive pericarditis, RV free wall, posterior left ventricular wall. You can see that the space between RV free wall and the posterior left ventricular wall is more or less constant. When the RV becomes big, the septum actually moves towards the LV. The LV is actually smaller and vice versa. If you're wondering, why isn't this posterior wall a straight line? I think it has to do with the fact that the M mode scan plane is moving slightly back and forth with the respiration. It's almost near not in the middle part of the RV. So that probably explains it. Now, this one is a classic M mode from constriction. In addition to the ventricular interdependence, which is marked here by the star, RV is bigger, RV is smaller. When the RV is bigger, the LV is smaller. Look at the posterior wall. This is called out in that document that I talked about. The posterior wall endocardium, it moves in nicely during systole, and then during diastole, it comes down rapidly. This is in relation to the very exaggerated rate of filling during rapid filling phase in constriction. And look at most of the rest of the endocardial movement during diastole, it is flat. So this is conceptually a very important point. In constriction, most of the ventricular filling takes place during rapid filling for a couple of reasons. The atrial pressures are high because the ongoing restriction of ventricular filling causes an elevation of atrial pressure. So when the mitral valve opens, there is a very quick gradient that causes the rapid filling to occur. But rapid filling is suddenly terminated because there is no space for the two ventricles to occupy. So most of the diastasis and late filling is completely flat. Now, this has a very interesting clinical application. In patients with constrictive pericarditis, loss of atrial boost is really not an additional serious problem. Or in other words, patients with constriction do not further deteriorate with the onset of atrial fibrillation because nothing much is going on in late diastole because all the filling is taking place here. We also know, just transposing this line of thinking to restrictive cardiomyopathy, patients with restrictive cardiomyopathy do poorly when their heart rate drops. They become more symptomatic because if you have very limited time to fill, and it is all limited to early diastole, if you slow the heart rate, you are actually increasing the amount of time the ventricle is just sitting with doing nothing during diastole, okay? So of course, there is a little bit of septal bounce and chaotic septal movement. And lastly, this bright line is the pericardium from the posterior wall. You can also see it in the 2D. Somebody could argue that, yeah, this may be some gain related. Probably not, because if you look at the 2D image up here, the thickening of the brightness is actually very limited to maybe about 4 o'clock position to about 7 o'clock position. So this was really from a patient with constrictive pericarditis and shows thickened pericardium. So again, this is our campus last fall. Thank you for inviting me to participate. And again, congratulations to Dr. Ashwath and Kofi and other fellows who were instrumental in putting in this together.
Thank you. We have two questions here for you. First one is, which of the findings in cardiac tamponade are more specific or sensitive?
You know, I think it is a little bit of a difficult question. I know it is something that is asked fairly often, you know, but something that I can say categorically is that right atrial inversion, the late systolic right atrial inversion is probably the worst. You know, it has very poor performance because right atrium is so thin-walled, and you can have a patient who is truly not tamponading show right atrial inversion. So if you are asking between right ventricular free wall, early diastolic collapse, and right atrial inversion, that is an easy answer. Now, if you put everything together, I really don't know what to tell you. And here is why. I know what works for me as a clinician, but I certainly don't want to give you a lead that will be contested by someone who is writing your exam questions. Because there are so many variables, including the kind of pathology that led to tamponade, presence or absence of free-flowing circumferential versus partially lockulated. I really don't know.
Okay. All right, the next question is, why do we take so much effort to look for all these echo features in tamponade if it is a clinical diagnosis?
The reason is, you know, I wish I could directly chat with that questioner. If you saw high jugular venous pressure and patient having tachycardia and hypotension, that's not enough to make a diagnosis of tamponade, correct? So you need an imaging. So maybe the questioner is saying that do a POCUS, point of care ultrasound, there is an effusion, and then you tap. There are, if you do that, I'm sure it happens, you know, but most patients with tamponade, they have a early course of slow worsening, which I believe we generally miss as clinicians because we don't think about tamponade. Number two is the tapping itself comes with some risk, right? You know, we recently had, we have seen patients where pericardiocentesis resulted in RV free wall puncture and worsening and so on and so forth. So the procedure is not totally innocuous. Plus, some patients with tamponade physiology have hypertension as they evolve to become hypotension. So there are lots of reasons why you should do a comprehensive study for confirming the diagnosis, following the patient. Plus, you are billing for a complicated study, right? So we got to do the due diligence to deserve that kind of whatever we are getting for our services. So I certainly think that the only time when you can do a study that is not comprehensive is when the patient is very sick.
How about commenting on having prior pulmonary hypertension and now developing tamponade?
Yeah, actually, you know, that's a very important question. I forgot to add that, particularly with right ventricular free wall early diastolic collapse, which we have mentioned more than once, as a very important, probably the most helpful echo finding in tamponade physiology. the genesis there is the intrapericardial being able to exceed transmural RV pressure because RV wall is thinner than LV. So in patients with RVH from any cause, RV pulmonary hypertension, RVH, from pulmonic stenosis and so on, you may have tamponade without RV diastolic collapse. That's actually it becomes much more complicated. So while we are on that subject, I should also have mentioned that the pulsus paradoxes may be absent in two conditions. Anyone in the audience want to answer that? They are aortic regurgitation and atrial septal defect. It's just a bonus point.
One last question. Is it true that you cannot really have tamponade physiology without IVC plethora?
That'll be highly unusual. It will be highly unusual. But here is the word of caution about that. A lot of times the scanning of patients with tamponade is very challenging, and if it is done by someone without experience, what you think is lack of IVC plethora may be a misdiagnosis. So I would just say that it is inconsistent with the physiology of tamponade not to have right atrial pressure elevation, and as such, without IVC plethora. This assumes that the study is done properly because the patient is breathing very heavily and your scan plane goes through IVC different ways during respiratory cycle, and it may look like the IVC is collapsing. But it's very small IVC, which completely becomes, non-visible during inspiration, will be inconsistent with tamponade physiology. The only exception for that may be localized LV tamponade after cardiac surgery, where there is a clot that is pressing the LV. So there are exceptions to that, but by and large, if it is a circumferential effusion and you are able to show that there is no jugular venous pressure elevation, no CVP elevation, no IVC plethora, the diagnosis of tamponade is almost, like you can bet some money on it.
Okay, thank you so much. Dr. Ashwath, over to you.
Thank you very much, Dr. Sivaram. That was excellent. Two excellent talks today and yesterday. Thank you very much for your contribution. Again, a very happy belated birthday to you. Thank you for doing this on your birthday weekend. Thank you all to the fellows who have joined us every week, 2 days a week for these lectures, and other people who are not fellows also. Thank you very much for joining. If you have any feedbacks or any comments, feel free to let us, any of the planning committee members, know about what we can do better for you. And again, the video recordings, as long as the speakers give permission, will be uploaded to our website. If again anybody has any thoughts, comments, or anything else, please let us know. Thank you very much for all the positive feedback we're getting. Thank you. Have a wonderful rest of the weekend and rest of the summer. We might plan some more lectures in the fall. If we do, we will keep everybody posted.
Bye-bye, everybody.